சுரேஷ் பாலனா சுரேஷ் பாலன் வரலைன்னா பரவாயில்ல, நானே மாடரேட் பண்ணிடுறேன்.
என்னன்னா சொல்றேன்னா இந்த மீடியா என்ன சொன்னாங்கன்னா யூனிவர்சிட்டி ரேட் ஒரு சில என்ன சொல்றா வந்துட்டு கொஞ்சம் அதாவது என்ன சொல்றாங்கன்னா அட்லீஸ்ட் என்ன சொல்றா நீங்க வந்துட்டு 2012 ரெஜிஸ்டர் பண்ணி எம்பிஎஸ் முடிச்சிருக்கீங்கன்னா நீங்க என்ன சொல்றா வந்துட்டு 60 கிரெடிட் ஹவர்ஸ் கண்டிப்பா இந்த நேரத்துக்கு அக்கௌண்ட் இருக்கணும். 60 கிரெடிட் ஹவர்ஸ் இல்லைன்னா கூட 30க்கு மேல அட்லீஸ்ட் ஒரு 1 மந்த் என்ன சொல்றா வந்துட்டு உங்களுக்கு ப்ராக்டிஸ் வந்து டீபார் பண்ண மாட்டாங்க. ப்ராக்டிஸ் வந்து பெனால்டி மாதிரி அப்படி பெனால்டி கட்டுற மாதிரி இருக்கும். அமௌண்ட் ஒரு பெனால்டி கட் பண்ணிட்டு என்ன சொன்னா நீங்க வந்துட்டு ப்ராக்டிஸ் பண்ணக்கூடாது. இப்ப எனக்கு கிரெடிட் ஹவர்ஸ் வந்து காரணம் என்னன்னா பாரு, எனக்கு காட்டுறேன் உங்களுக்கு. என்னோட கிரெடிட் ஹவர்ஸ் 36 மேல போயிடுச்சு. நான் இப்ப டீச்சிங் ஃபேக்கல்டி வருஷம் முடிச்சு நான் 18 கிரெடிட் ஹவர்ஸ் அது 18 வருஷம் இருந்துச்சு. அப்புறம் கர்நாடகா ஒரு டைம் போயிட்டு வந்தேன், பெங்களூர் போயிட்டு வந்தேன், தெலுங்கானா போயிட்டு வந்தேன், அப்புறம் சீமியா நடக்கும் மதுரையிலே நடக்கிற, அப்புறம் ட்ரெண்டோ போயிட்டு மதுரை பெடிக்கான் அப்புறம் இந்தியன் அகாடமி அட்டன் பண்றது ஜூன் மந்த் இப்ப இந்த 5 கிரெடிட் ஹவர்ஸ்
இன்னும் ஸ்டார்ட் ஆகல. இனிமேல் தான் ஸ்டார்ட் ஆக போகுது. ஸ்டார்ட் ஆகல. ஒவ்வொருத்தரும் ஜாயின் பண்ண ஆரம்பிச்சிருக்காங்க. இன்னும் கம்ப்ளீட்டா முடியல. 295 சம்திங் தான் ஜாயின் பண்ணிருக்காங்க. இது பண்ணா போதும், நம்ம மெடிக்கல் கவுன்சில் நம்பர் எழுதுனா போதும், ரொம்ப பெரிய லெவல்ல எழுத வேணாம். மெடிக்கல் கவுன்சில் நம்பர் எழுதுனா போதும். യൂട്യൂബിലെ നമ്പർ
സാപ്പാട് എല്ലാം കൊടുക്കാം, പക്ഷെ ചൂട് ജാസ്തി മാട്ടുപാൽ കൊടുക്ക കൂടാതെ. മാട്ടുപാൽ അവിടെ ജാസ്തി വേണ്ട, പക്ഷെ ചോറ് കഞ്ഞി ഇഡ്ലി ദോശ അതുമാതിരി എല്ലാം കൊടുത്തിരും. നെയ്യ്
Sir, good afternoon, sir. Sengatun, sir, good afternoon.
Good afternoon, sir. Name is sir. Good afternoon.
நல்லா இருக்கீங்களா சார்?
இருக்கு நல்லா இருக்குங்க.
செந்தில், good afternoon, செந்தில்.
சார் குட் ஆஃப்டர்நூன் சார். குட் ஆஃப்டர்நூன் சார். சார் அப்புறம் ரகுநந்தன் சார் வந்திருக்காருங்க சார். அவரு ஜாயின்
ரகுநந்தன்
பண்ணிட்டாருங்க
சார் ஜாயின் பண்ணிட்டாரு. பட் இப்ப கார் டிரைவ் பண்ணிட்டு இருக்காரு. இன்னொரு 5 minutesல உள்ள வருவாருங்க சார்.
ஓகேங்க சார். அவரோட டிஸ்ப்ளே நேம் மட்டும் தெரிஞ்சா கோ-ஹோஸ்ட் பண்ணிடுவாங்க சார்.
சொல்லிடுறேங்க சார். ஆல்ரெடி லிங்க்ல வந்துட்டாரு. சுரேஷ் சுரேஷ் பேசிட்டீங்களா?
ஓகேங்க சார்.
அப்போலோ
நான் காலையில பேசினதாங்க சார். மெசேஜ் பண்ணாரு. சுரேஷ் குமார்
போன் நாட் ரீச்சபிள்னு வருது.
பாத்துக்கலாம் சார்.
சார் செங்கடூன் சார், குட் ஈவினிங் சார். செந்தில் சார், குட் ஈவினிங்.
ராஜ்குமார், குட் ஈவினிங் ராஜ்குமார்.
நேம்லேன் சார், குட் ஈவினிங் சார்.
குட் ஈவினிங் ராஜ்குமார், எப்படி இருக்கீங்க?
சார் நல்லா இருக்கேங்க சார்.
நல்லா இருக்கீங்களா? ராஜ்குமார் எப்போ அந்த ஸ்மைல் அந்த எனர்ஜி தான் ராஜ்குமாரோட பிராண்ட் மார்க்.
தேங்க்ஸ் சார். தேங்க்ஸ் சார்.
வெரி குட்.
லாகின் 500 கிராஸ் பண்ணிட்டாங்க.
வெரி குட் சார். செந்தில் பெரிய செங்கடூன் சாரும் செந்திலும் பெரிய ஹிஸ்டரியே கிரியேட் பண்ணிருக்கீங்க.
ஆமாங்க சார்.
வெரி குட். உங்க டீமுக்கு எல்லாத்துக்கும் வாழ்த்துக்கள்.
தேங்க்யூ சார். தேங்க்யூ.
1000 லாகின் இதுதான் ஃபர்ஸ்ட் ஏங்க சார் ஹிஸ்டரியிலேயே.
ஆமாங்க சார்.
1000 பேர் லாகின் பண்றாங்க. 5 நாளும் 1000 ரீச் பண்ணிட்டோம். 5வது நாளும் இன்னைக்கெல்லாம் 1000க்கு மேல போயிடுவோம்.
Sir, we will start by 4, sir. Another 2-3 minutes.
We can start. ஹலோ, என்னம்மா? ஆமா, என்ன தொந்தரவு? சொல்லுமா, பேசு. என்னடா? Sir, shall we start?
Yes, sir.
With the program, sir. Me,
Shall we start, Sendil?
sir. To higher institution. Sir?
Sir?
Yes, sir.
Meeting call to order. Now I request Rajkumar sir to give IMA prayer and vision prayer.
Good evening, everybody. IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every creed and lure. Physician player, dear God, thou great physician, I kneel before thee. Since every good and perfect come from thee, I pray. Give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow man, and a true realization of the rare privilege that is mine. Take from my heart all guilt and worldliness, that with the simple faith of a child, I rely on thee. Thank you.
Thank you, sir. Now I request our Director of Studies, Dr. Sengatuvan sir, to give its welcome address.
Good evening to all. In this current CGP program, the last day we are going to witness the monsoon illnesses by Dr. K. Naminathan. He is going to speak about the leptospirosis update. Dr. Raghunandan, who is going to talk scrub type fever, and Dr. Suresh Kumar, who is going to talk, Raghunandan is going to talk diagnosis and OP management of dengue, and Suresh Kumar, scrub typhus. In this occasion, I welcome Dr. Naminathan, Raghunandan, and Suresh Kumar for this CGP program. And I also welcome all the participants who is going to enlighten their knowledge by the current CME program. Thank you, sir. I once again welcome all the speakers. Thank you.
Sandil sir?
Yes, sir. Sandil sir, what is the next agenda, sir?
Next agenda is the introduction of the speaker and everything, sir.
State President Secretary எதுவும் வராங்களா sir?
இல்ல சார் நினைக்கிறேன்.
Okay. Sandil, shall we go ahead?
Mike, handed over to you, sir.
Thank you, sir. Thank you. Good afternoon, friends. At the outset, greetings from Dr. Naminathan, Coimbatore Child Trust Children's Hospital. My sincere thanks and appreciation to my elder brother, Dr. Sengatuvan sir, a senior pediatrician and also dynamic leader who has taken CGP to greater heights. And my sincere thanks to my younger brother, Dr. Sendil Kumar, my Woods from Pollachi, who has taken hardship to bring more than 1,000 members for this CME. My sincere thanks to my younger brother, Dr. Rajkumar, and other members of this CGP Tamil Nadu chapter for having taken this initiative on the right time. Friends, I'm sure you will all agree with me, particularly doctors in the Western Belt would have seen surge in the increase in the cases of fever in our day-to-day practice. For example, in our hospital, our outpatient has doubled during the past 2 weeks. So whenever the rain comes, it brings lots of joy, merry, happiness around the people's mind. At the same time, unfortunately, we have a sudden surge in the cases of fever. The most important question we as practitioners, particularly pediatricians and adult physicians, general practitioners, have in our mind is whether this given fever in the child is a viral etiology or does it have a bacteriological cause. That is the empirical diagnosis. The first thing what we need to do is to arrive at an empirical diagnosis. So most of the time, the $1 million question is to prescribe antibiotics in our day-to-day practice or not. As per the randomized control studies done on short pyrexial illnesses in pediatric OPD, vast majority of the monsoon illnesses are viral in nature and they do not require antibiotics. Even in my own practice, when I started my career around 30 years back, the moment I finished my post-graduation, my antibiotic prescription was nearly 90% of the time for simple short pyrex illness. It was prescribed. Now it has come to less than 9% of the time. So 91% of the fevers during the monsoon do not require antibiotics. So how to arrive at an empirical diagnosis within a short span? So I'm going to tell you a 5-point rule which you can apply so that you can arrive at a diagnosis, whether it is a viral, whether it doesn't require antibiotics, in a matter of 5 minutes. So it starts with a proper history and a head-to-foot thorough examination. So let me start with the point number 1. When you have a child with sudden onset of fever in a previously healthy child, is probably viral in nature because most of the viral fevers have short incubation period, ultra short incubation period. Bacteria have got long incubation period. If the child gives a history, if the mother gives a history, there are more than one member in the family having fever at the same time, it probably swings the pendulum towards virus because viruses have got ultra short incubation period. Within a day or two, more than 1 or 2 members in the family having the same illness, that swings the pendulum towards virus. And the third is multiple sites that's involved. If you look at the child, the eyes is red, throat is congested, nose is watery, multiple sites involvement, dissemination, hallmark of virus, probably it swings the pendulum towards virus. And regarding the system involvement, there are more than one system that is involved. For example, in GI, there's a watery diarrhea. In the skin, there is a rash with itching. In the respiratory, there is rhonchi and rolls with the dry hacking cough. So more than involvement of more than 1 or 2 systems, along with fever, swings the pendulum towards virus, whereas bacteria localizes to only one system. And the last 5th point is that when you give paracetamol, the fever subsides, the child becomes up and about active playing. That is called interfebrile period, the period between 2 fevers. When the child is active, probably it's viral. By applying this simple 5-point rule, you can make a diagnosis of whether it's a viral or a bacterial in a matter of few minutes. So just start applying this rule, and in every patient whom you encounter with the fever, you will be able to make a reasonable diagnosis with a sensitivity and specificity of more than 95% in your day-to-day practice. Your antibiotic prescription, your antibiotic stewardship will be excellent, and unnecessary antibiotics can be curtailed in vast majority of the viral illnesses. With this introduction, let me go to the topic of today that's called leptospirosis. Friends, if you look at the zoonotic diseases that man gets from the animals, on an average, every 4 minutes throughout the world, globally, one human being gets a zoonotic disease. But fortunately, vast majority, 99.99% of the zoonotic diseases has a self-limiting course. It will settle down with a single person. Unfortunately, for example, in 2009, the Mexican lady who got the flu from swine, from a pig, transmitted the illness to the entire globe. That was a swine flu epidemic. Unfortunately, from China, we got the COVID epidemic. Most of these epidemics, pandemics are caused by viruses. So many of the zoonotic disease self-limits. Fortunately, one among such disease, the commonest disease is leptospirosis, otherwise called field fever or a Wheels disease, or a 7-day fever or a paddy field fever. It was found out first in 1886 by Dr. Adolf Field. The incidence globally is around 7 to 10 million annually globally. But unfortunately, in India, we don't have a national data. But looking at the papers that is presented in various journals in India, we could find a surge in the incidence of leptospirosis, particularly the states on the western border, whoever receives monsoon rain during the months of June, July, August. They are starting from down Kerala, Karnataka, Maharashtra, Gujarat, and also including Andaman Nicobar. Friends, Tamil Nadu has got a wide, lengthy Kerala border. So any fever, they don't see whether it is Malayali or a Tamilian. From Kerala, it can anytime jump into Tamil Nadu. So this is the right time we have to enrich ourselves with the knowledge about the zoonotic disease, particularly the one that is called, in Kerala, they call it as Elipani. Tamil Nadu, we call it as Elikachal. It's a leptospirosis. We need to upgrade ourselves with the knowledge about leptospirosis. Friends, let me take you to the causative organism. You would have seen in your microbiology a corkscrew type spirochetal organism that's called Leptospiro introgans. It's a commonest organism. And the most interesting part is that it's a disease of the animals. In wild animals, it's common in rats, mice, and rodents. In domestic animals, cattle, sheep, goat, buffalo, they harbor these organism. And the quite interesting part of that is that once they get infected, if they are not recognized and treated, they continue to be a source of infection. They infect through they are infective throughout the lifetime. They pass urine with spirochetes. And another interesting thing is a slight heat, that is boiling the water up to 60 degrees for 10 seconds will kill the spirochete. So they are amenable to heat and also to chlorine. At this point of time, I like to tell you that Neraya organisms are highly fragile. One among them is Leptospira. Another important thing is rabies. Suppose if you put a drop of antiseptic on your bite site, rabies will disappear. Virus will get that neutralized. So this Leptospira, by heating or by reduce the incidence to nearly practically zero. So looking at the saline features, this, once you get a Leptospira, but a particular serovar, there are more than nearly 100 serovars. So the antibody produced do not have a cross protection against other serovars. So one can get repeated attacks of leptospirosis if you are not safe. And as I told you, human infection is an accidental. Basically, it's a disease of animals. And the infected animals can pass urine with spirochetes, which will survive for 2 to 3 weeks. In winter season, rainy seasons, they can even survive up to 4 weeks. And the transmission from the infected soil to the human is either, majority of the time, more than 90% by direct. If there is a minor scratch or a wound in your feet and then you visit a farm site or a paddy field, these organisms directly enter into the bloodstream. Indirectly, if you take vegetables, if you don't wash, that vegetable is contaminated with the infected animal's urine. You get indirectly by ingestion, and rarely droplet. And I'm sure the undergraduates who are attending this conference will know that the incubation period is between 7 to 12 days. Once the organism enters, it directly goes to the bloodstream. There is a spirochetemia. Then from there, once the antibodies, particularly IgM antibodies, appear around 7th day to 10th day, then they neutralize all the organisms. The blood organisms in the bloodstreams disappear. But at the same time, the body having produced IgM antibodies, these organisms enter into the organs, particularly liver, kidney. So that is particularly this organism is a nephrotropic organism. Each organism has got tropism. For example, flu virus has got pulmotropic, it goes to lungs. This organism enters into liver and kidney. If we look at the pathogenesis, what happens is these organisms release endotoxin. Another important thing is organism, that is the antigen, and the antibodies, IgM antibody, form antigen-antibody complexes. They get deposited in the medium-sized arteries, causing vasculitis. From the vasculitis part, there is a capillary leak. There will be intravascular dehydration. Then there will be hemorrhage. And third space, fluid accumulation. If you carefully look at this chain of events that exactly happens in dengue. It exactly happens in typhus fever. So all these three diseases, dengue, scrub typhus, and leptospirosis, are called sister diseases. Each has got the same spectrum of etiopathogenesis. So it's our duty to differentiate whether it is a given child's fever, whether it's dengue or leptospirosis, scrub typhus, just by applying our knowledge. With your clinical knowledge, you can come to a diagnosis, what is this organism. I'm going to give you a simple clue how to identify the organism just by looking at the child, taking a proper history, and also just by doing a simple CBC, you can arrive at a most probable cause of the fever. So let's go to the natural history. Once the organism enters, vast majority of the illness, the nature cures, 90% of them will come to your hospital or your clinic with a mild or a high-grade fever, with a headache, with severe myalgia, sometimes with a cough, sometimes with abdominal disturbance. And you would have made a diagnosis, probably viral. You would have given paracetamol. Neither the patient nor the doctor will know the patient has got leptospirosis. Fortunately, it's a self-limiting illness in vast majority. Without your medicines, they will become all right. But unfortunately, organ involvement, particularly lung involvement, is life-threatening. So you have to always keep leptospirosis in the back of the mind if there are following scientific evidence, which is the last slide. So if you look at the mortality, in general, the mortality in a simple leptospirosis is practically zero. Whereas in severe form, the mortality may rise above 5%. If you look at the main symptomatology is high-grade fever associated with chills and headache. Another important finding is sweating. So if you look at these each symptoms, I'll tell you what are the classical symptoms that you need to watch. And a majority of these children will have severe myalgia. They'll be brought by child be lifted and put on your couch. They will have myalgia, arthritis. The most important thing, almost majority, more than nearly 60 to 70% of these children with leptospira will have conjunctival suffusion. So I am going to elaborate upon these important symptoms later in my slides. Okay. So if you look at the clinical manifestation, basically leptospira has got anetric fever and an ectric fever. Anetric fever constitutes nearly more than 90 to 95%. Ectric fever usually less, particularly it's practically zero in young children. It's more common of a disease of children, adults more than 30 years. Basically, like dengue, leptospira is a biphasic fever. That is, there will be fever for around 3 to 7 days. By around 7th day, the fever will disappear and the child will be afebrile. The mother will be happy because the fever has disappeared. But unfortunately, the complications arises after the disappearance of fever. So it's a duty on the part of every physician who attends the CME to educate the parents that whenever you get a child during a monsoon time, whether it is dengue or a scrub typhus or leptospirosis, you have to tell them to come for regular follow-up even after the disappearance of fever. You have to tell them the complications such as reduced urination or abdominal pain or a hemoconcentration causing organ involvement or hemorrhages can happen after the disappearance of fever. So counseling is very, very important in every child with leptospirosis. So as I told you, the first phase, there will be spirochetes in the bloodstream. Once the IgM antibodies enters the circulation by around 5th day to 7th day, the fever disappears. Child enters into afebrile period or a period of danger symptoms. And the second phase is called, following the afebrile period, is called immune phase, in which child develops a fever, small hump of fever. After 10th day, that is because of the immune-mediated fever. So it's otherwise called camel hump fever. இந்த ஒட்டக சிமிங்கி பாத்தீங்களா, முதுகுல வந்து 2 திமில் இருக்கும். ஃபர்ஸ்ட் ஒரு திமில், பின்னாடி ஒரு திமில். இந்த நடுவுல அந்த சாடல் மாதிரி இருக்கிற திமில், அந்த பீரியட் தான் காம்ப்ளிகேஷன்ஸ் வரும். So the parents will be happy during the afebrile period. We have to be very, very cautious during the afebrile period. That's an important message in this slide. So as I told you, anectric form is vast majority. It's a self-limiting mild form. Usually they come to you with fever and myalgia, and classically they don't have jaundice. And the most important thing is particularly young children less than 14 years of age. Nearly 25% of these children with leptospirosis will come to you with a aseptic meningitis. That is, they may have severe headache, vomiting, they will have meningeal signs. These children, though it's a meningitis, vast majority of them will come out satisfactorily just with proper treatment and observation. So the mortality is less, but it's imperative on the part of the doctor to observe for development of signs like headache, vomiting, and high-grade fever, particularly developing signs of meningitis like neck stiffness, Kernick sign positive in these children, particularly those who have aseptic anectric leptospirosis. So, like looking at the three important cardinal symptoms of leptospirosis. One is myalgia. In a dengue, you can have myalgia because dengue is called break bone fever. How to differentiate between dengue and leptospirosis? It's very, very, very easy. If the child has got a severe cough pain with abdominal cramps and a lumbosacral pain, probably you're dealing with either dengue or leptospirosis. The single test that can differentiate between two is that serum CPK. Serum CPK is highly elevated, it's probably leptospirosis. And looking at the eye, if the child has got suffused conjunctiva, that is the eye, both conjunctiva is suffused. If it is bilateral, more on the palpebral conjunctiva, sometimes you can have hemorrhage also. It's probably swings the pendulum towards leptospirosis. And another important thing is the child has got a throbbing headache, particularly on the frontal region, bifrontal region, above the eyebrows, which relieved promptly by paracetamol. It's probably a combo of high-grade fever with chills, with severe myalgia, with elevated CPK, conjunctival suffusion, headache, is most probably you can make a diagnosis of empirical diagnosis of leptospirosis. Even without jaundice, you can make a diagnosis because vast majority of the leptospirosis are anectric in nature. So let's see about the etric part of the leptospirosis. That's otherwise called Beale's disease. It's very, very rare, particularly in children. It's less than 1%. In adults, less than 30%. It's a disease of more than 30 years. It's characterized by jaundice, renal failure, thrombocytopenia, extensive hemorrhage, particularly pulmonary hemorrhage, which is cause of death, and cardiovascular collapse can happen. If you look at this Beale's disease, if there is a combo of this combination, it's called Beale's syndrome. A combo of a severe disease with liver and kidney involvement, it's called Beale's syndrome. Most of these children, when they enter into the afebrile period, make the child lie down and put your hand on the liver, see for right hypochondrial pain. If there is a tender hepatomegaly, either you are dealing with either leptospirosis or a dengue, particularly during this monsoon illness. So next thing is you ask for the history of oliguria or anuria. That's very, very important. Normally a child passes around 1 ml per kg per hour. That is a 10 kilo child should pass around 60 ml every 6 hours. The mother says child hasn't voided urine for more than 6 hours or 12 hours or 24 hours. He is a candidate for admission. The child has got a right-sided hypochondrial pain with a tender hepatomegaly. Do not give them antacids or PPA and send them home. That's a candidate for admission. So sometimes the renal involvement can be microscopic hematuria or a proteinuria. You have to do a urine microscopy, see for hematuria. And rarely children can go in for acute kidney failure, which can even be fatal. But the commonest cause of death in children following leptospirosis is pulmonary involvement, acute pulmonary pneumonia with pulmonary hemorrhage. And if you look at the lab parameters, these children with Beale's disease can have serum bilirubin that is grossly elevated, both direct and indirect. Alkaline phosphatase will be elevated. But dramatically, they will have a near normal SGOT-PT with an elevated CPK. This combo will give you clinch the diagnosis of leptospirosis, because another illness, in particularly in young children with jaundice, is infective hepatitis, wherein you have grossly elevated SGOT-PT, particularly in hepatitis A, which is common during monsoon. There you will have SGOT-PT in thousands. So let's briefly go to the lab diagnosis. The most important thing what we do in our day-to-day practice is CBC. Never do CBC on day one for any illness, because vast majority of the illness, CBC will be normal on day one. It will put you into a lot of troubles. They will come back to you on third day. If you do CBC, then the problems will be found in the CBC. The mother will ask you, you said normal, now you are telling abnormal. So never do CBC on day one and day two. Preferably take time to do CBC after 48 hours. In leptospirosis, you can have polymorphonuclear leukocytosis. That's very, very important. And you can have an elevated ESR. The most important thing is children with severe myalgia, usually they have elevated CPK, and some of the children can have thrombocytopenia. The gold standard for the diagnosis of leptospirosis, particularly from day 3, is microscopic agglutinin test. More than 800 units is significant, but unfortunately this test is not done routinely. Though it has got a good sensitivity of 92% sensitivity and specificity of 95%, it's done in metros like Chennai. Whereas if you're practicing in a small place, what you can do is you can do IgM ELISA, which will be positive after 7th day of illness. Or if you do a leptospira agglutinin test, when there is a 4-fold rise, it could be a easy diagnostic factor. So do not rely upon rapid tests, because false positivity and false negativity is very high. The government of India and the WHO does not recommend CAR tests both in dengue and leptospirosis. So let's briefly look at the differential diagnosis. I'm sure I told you dengue is the closest differential diagnosis of leptospirosis, because they carry the same etiopathogenesis and they carry the same natural history. So when I tell dengue, there are some viruses that belong to the same family. They are called viral hemorrhagic fevers. It could be dengue fever or a chikungunya, or it could be ong-yong fever, or many of the viral illnesses with hemorrhagic tendency. They are all called viral hemorrhagic fevers. And the next commonest is, particularly during monsoon, is influenza. And of course, viral hepatitis tops the list in differential diagnosis. Please keep typhus and typhoid in the back of the mind. So always thoroughly undress the child, look for hidden areas, particularly behind the ears, in the inguinal region, in the intergluteal fold, behind the scrotum, to see for Escher, the bite by the thrombophilic mite. So that's called sugar. If it is there, it's called Escher. Escher is nearly present in 60 to 70% of children with typhus. Always keep malaria and yellow fever in the back of the mind. And whenever child has got meningism and headache and vomiting, keep meningitis, aseptic meningitis, and children with chills and rigors, keep pyelonephritis in the back of the mind. These are the 8 diseases. Whenever you encounter leptospirosis, you have to keep a watchful eye, and your knowledge will help you in identifying which is illness. So by looking at this complication chart, the most commonest complication happens in leptospirosis is the renal involvement, particularly acute renal failure. But this is not the commonest cause. As I told you, acute pulmonary involvement like pneumonia and pulmonary hemorrhage is the commonest cause of death. So if you have to prevent death, particularly in young children, you need to act early. Starting the appropriate treatment early will solve the problem by reducing the mortality to nearly 0. So coming to last few slides, if you look at the standard textbook of medicine like Nelson, Harrison, the wonder drug that we practice in our day-to-day practice, particularly in pediatric institutions like us, is penicillin G. The dose is 6 to 8 million units per meter square per day. It's given 4th hourly IV for 7 days. But for various reasons, if you have difficulty in getting this drug or difficulty in infusion giving 4th hourly, the best and the simple alternative in children who are admitted in the hospital is cefotaxime. If the child is in anitric phase, you can use ceftriaxone, or if the child is in itric phase, you have to use cefotaxime. And the best oral in children who are clinically stable, those who do not require hospitalization, or 2. In children more than 8 years of age, you can use doxycycline 4 milligram per kg per day, given 2 divided doses for a period of 7 days. You will be wondering about this wonder drug. This is a drug of choice for leptospirosis. This is a drug of choice for scrub typhus, and also in very severe dengue where the child is in cytokine storm. This drug has got anti-TNF and anti-IL-6 action. So it will reduce the cytokine storm. This is a wonder drug, life-saving drug for all the 3 monsoon illnesses. In children less than 8 years of age, you can use azithromycin, the dose of 10 milligram per kg, single once a day, OD for a period of 7 days. The most important message in this slide is that by your appropriate clinical diagnosis, you can make an empirical diagnosis, start an antibiotic therapy, which reduces the complications, mortality, morbidity, and also hospital stay to a greater extent. The aim of this particular monsoon CME is to educate all the doctors in Tamil Nadu about monsoon illnesses and to reduce, join with the government of Tamil Nadu to make a zero mortality state. So at this juncture, I would like to appreciate our state government, Department of Health, for taking very energetic steps in controlling various illnesses in our state. And I'm really proud that I belong to the state of Tamil Nadu, where the health indices are one of the best. And also at this juncture, I would like to appreciate the central government for taking various initiatives to control these monsoon illnesses. So let me come to the last part of the slide. In this slide, friends, I like to tell you, whenever you have diseases like dengue or a leptospirosis or a scrub typhus or a malaria, simple tool that you can use in your day-to-day practice is do a CBC after 2nd day. In a CBC, if you have leukopenia with the increased hematocrit, that is hemoconcentration, with thrombocytopenia, most probably you are dealing with dengue. In the CBC, suppose if you have polymorphic leukocytosis, and if the CPK is elevated with elevated ESR, and a child with a bilateral conjunctival suffusion with a bifrontal headache, you have to think of leptospirosis. That is a clinical clue. Suppose the same child has got a biphasic fever. If you do CBC, on thorough examination, you find a SR, or you find a splenomegaly with a coated tongue with a bradycardia, you do a CBC, and if there is a eosinopenia is always a secret that you can tell this child has got either typhus or a typhoid. So by looking at eosinophils, you can tell this child has got typhus or typhoid. And the last important disease is malaria. By looking at CBC, most of the time in malaria, you can have a normal WBC, normal platelets. Hemoglobin may be low because of the anemia. The most important thing is in malaria, you can have eosinophilia. That is, the eosinophil count will be very high. So in such a situation, the child has got a massive splenomegaly, fever with chills. You can think of malaria. Immediately you have to do peripheral smear to look for thin and thick smear to look for malarial parasite. So all these 4 diseases, by using your clinical knowledge, by taking a proper history and applying your knowledge in the given patient and doing a simple CBC, you can come to a diagnosis. The last important carrier message for doctors who are practicing in Kerala border, right from Kanyakumari up to Coimbatore. Those who have a common border, is that now leptospirosis is endemic in Kerala. When you have a child with high-grade fever, with severe myalgia, conjunctival suffusion, please consider every child as a suspected leptospirosis. Please monitor the child. You need not unnecessarily prescribe antibiotic. This child needs a close monitoring, and also you have to educate the parents about warning signs. If you do a close monitoring and a proper education, you can make your practice successful. With that, I like to thank once again CGP Tamil Nadu chapter, Dr. Sengutuvan, Dr. Sendil, Dr. Rajkumar for giving us this wonderful opportunity. Friends, those who want my slides on leptospirosis, you can contact me in this number 98422 11179. You can note it down 98422 11179. At the end of the meeting, you can send a personal request by WhatsApp to me. I'll send you all the slides for your learning purposes. So with sincere thanks, my folded hands, I appreciate the entire team for giving us this opportunity. The questions will be at the end of the meeting. I now request my friend, Dr. Raghunandan sir, to join this CME to enlighten us about the management of dengue in the OPD practice. Sir Raghunandan sir, please.
Yes, sir. Am I audible, sir?
Yes, sir, you are audible. You can start sharing your slides, sir.
Yeah. Slides are visible, sir?
Slides are visible. You are audible. Sir,
Yes, sir.
Sir, shall I take a minute to introduce yourself?
Yeah.
Friends, here we have a person, eminent person. I'm sure all of you know Dr. Raghunandan sir. He is a nationally eminent person and who was the COVID nodal officer for entire Tamil Nadu. He is a professor of medicine, Madras Medical College, and chief of IMCU and the Poison Control Training Center in Government General Hospital, Chennai. And he is my close friend and my one of my partners in IMA CGP Infectious Disease Certificate course. Friends, myself, Dr. Raghunandan sir, and the retired Director of Public Health, Dr. Kulendeswamy sir, along with Dr. Mohan Kumar, a renowned epidemiologist who is in Infectious Disease Center in New Delhi, and Dr. Surya Kumar, microbiology professor. We have Infectious Disease Certificate course through IMA CGP Tamil Nadu State Chapter. Those doctors who are joining this CME can immediately at the end of the meeting can contact me in my previous number I told you to join this certificate course. This course has been recently started. Still registration is going on. So this is a 6 months online course till December 2023. You can join the course as early as possible. Friends, at this juncture, I would like to hear from the horse's mouth, Dr. Raghunandan sir. The stadium is yours. Please go ahead, sir.
Thank you. Thank you very much, sir. First of all, I would like to thank the CGP Tamil Nadu branch of Indian Medical Association for arranging this CME. And I think the continuous CME program of 5 days, and today is the last day. And also my special thanks to Dr. Neminathan for introducing me. So I think today we are going to learn about 3 important topics, which one already Dr. Neminathan has touched on, leptospirosis. So my job is on dengue and to be followed by scrub typhus. So whatever I'm going to share today with all our listeners is our experience in the last, almost I would say last 15 to 18 years of managing this acute febrile illness, especially as far as dengue is concerned. Our state has seen many outbreaks in the last 1.5 decades, I would say. So I would share some of our real-time experiences in managing this dengue in the field as well as in the inpatient. And today's talk is going to be more on outpatient management also. But I personally feel if the proper management is outpatient is there, I don't think we should lose even one case. So in fact, the target of our government of Tamil Nadu is no death due to dengue. So if you want to achieve zero death due to dengue, I would personally feel that it is on the primary care physicians where the patients are first seen. So I'll just take you around the clinical profile and the lab investigation and management protocols. And as and when we'll try to discuss, already Dr. Neminathan has touched upon the other differential diagnosis of acute febrile illness when you are talking about lepto. So I would also like to touch upon those points. But at a busy practice, I know in our busy practice in a OPD, especially in a rural, urban and rural setup, hardly we spend around maximum 3 to 5 minutes with one patient. So our assessment must be so quick that whenever we handle a case of acute febrile illness, so our first aim is to arrive at a probable clinical diagnosis. Number 2, does he need further investigation? Number 2. Number 3, does he need does he need inpatient admissions? So these are the 3 important decisions that we have to take very quickly on how to have a follow-up. So with this background, we'll just go through the thing. Again, I'm going to start with a very interesting epidemiological data. Just look at this particular slide where you can see in a village, suppose we assume that in a village, if 100 people are infected with the dengue virus, we know the vector is Aedes aegypti. If the vector has given the virus to 100 people in the village, so they'll be harboring the viremia. So the dengue virus will be circulating in their blood. Just look at the symptomatic and asymptomatic. Nearly 75% of them will be asymptomatic. That means even they are harboring the virus in the blood, they may not have any symptoms. What is its significance? I'll come to that. So out of that, 25 will become symptomatic. So what are the common symptoms we're going to learn? Again, the most common symptom is the fever. Sudden onset of fever with tiredness, fatigability, vomiting, diarrhea, like that. So if you look into the symptoms also, as far as dengue uncomplicated is there, around 95%, maybe up to 99%, can be a mild to moderate form. Only 1 to 5% may land in severe dengue. And again, if you are able to recognize this severe dengue at an early phase and preventing them to going to a multi-organ dysfunction. The key word in understanding dengue problem is we should not allow even one patient with dengue to land up with multi-organ dysfunction. Why I am stressing that particular point is if a child to multi-organ dysfunction in a case of dengue, the mortality is more than 95%. Number 1, early diagnosis and early recognition of complications. That we'll try to understand. So I'm coming back to the asymptomatic phase. So even if one patient is reported in a village, we have to assume that so many, around 75% or 75 people will be harboring the virus. What does it mean? From the public health point of view, they will be silently spreading the virus in the community. So that is why compared to other diseases like lepto or scrub, why dengue has got so much of public health importance, because it is a silent bomb. So even if one case is reported, the public health people will survey the whole village so that they don't want these asymptomatic people to be the sources for the spread in the community. So this is the overall understanding about the epidemiological aspects of dengue. Again, I think any talk on dengue cannot be completed without going through this slide. Even in my previous talks for IMA or whenever I visit any district programs, I have been talking on this slide because once this slide is understood. So friends, I request all of you to pay attention for at least 5 to 10 minutes to understand this particular slide so that subsequent slides will be easy for us to go through. The clinical management will be very, very easy. So what are the important learning points from this particular slide? Again, this slide has been given in the WHO website, but it's a very good slide to understand the 360-degree aspects of dengue. So I'll try to highlight the most important aspects so that we can know what is needed for our clinical management. So we'll just look into this slide. The top corner top says the duration of illness, which is around 10 to 12 days. Coming back to the lower part, again, this 12 days disease is divided into 3 phases. I'm sure all of you would have heard this many times, so I'll just try to go quickly just to recollect or to refresh our knowledge. Maybe in the question answer, if you have any other doubts, we'll discuss it later. So I'll just quickly go through this slide. So duration is 12 days. So that is divided into 3 phases like febrile phase, critical, and recovery phase. And what they have done in this slide is they are trying to capture the important clinical laboratory events during these 3 phases. So first parameters they have captured is the temperature. Next, what are the possible clinical issues that can occur during the dengue phase? Then what are the laboratory? 2 important, there are many laboratory tests, but as far as our clinical management is concerned, we are more focused on hematocrit, that is PCV, and the platelets. Then finally on the diagnosis of dengue, that we are focusing on NS1 antigen and IgM and IgG. So we'll try to understand each component. So first we'll go to the temperature chart here. I think all of us know whenever a patient comes, even in your OPD practice, try to record the temperature and make a entry in the OP ticket. Whatever OP ticket you are following, please put it so that when the patient comes back tomorrow, next day, even you can ask them to maintain a temperature, even if you are managing as an outpatient. I request the doctors to ask the patient to record the temperature at least 6th hourly, maybe 4th hourly, and make a record in the OP ticket so that when the next day he comes for follow-up, it will be easy for you to look at the profile of the temperature, which is very, very important to understand. So just look at the temperature here. So most of us know whenever we handle a patient with fever in our OPD, the first question that might arise is, am I dealing with dengue? What should make me to strongly suspect dengue when an AFI patient reports in my clinic? The answer is very, very simple. The first clue is sudden onset of high temperature. If you look into this temperature chart, just look at when is the maximum temperature in dengue, day 1 and day 2. So நம்ம history கேட்டீங்கன்னா, சார் டாக்டர் நான் நேற்று வரைக்கும் நல்லா இருந்தேன், ஊருக்குலாம் போயிட்டு வந்தேன், I was fine yesterday. நைட் வந்து படுத்தேன் டாக்டர், காலையிலேருந்து என்னால முடியல, ஜுரம் கொளுத்துது, ஜுரம் அதிகமா இருக்கு, என்னால முடியல. So the 3 key words which we always give more importance, it's a very, very important carry home message. 3 important words: tiredness, fatigability, and lethargy. டாக்டர் ஏதாவது பண்ணுங்க, என்னால முடியல, ரொம்ப உடம்பு அடிச்சு போட்ட மாதிரி இருக்கு, ரொம்ப சோர்வா இருக்கு, ஏதாவது பண்ணுங்க. யார் சொல்றா? 15 year, 20 year, 30-year-old person. Otherwise, who was a healthy adult. So why I'm stressing this point is that is an important warning symptom. So one is sudden onset of more than 103, 104 fever associated with other symptoms. All of you know. Already said is also touched about the different types of fever. So dengue is called as break bone fever. So if a bone is broken, how much pain you will feel, that is equivalent in dengue. So sir was mentioning about myalgia, myositis, that is characteristic of leptospirosis. That is myositis. Muscle pain, leptospirosis. Joint pain, more towards chikungunya and dengue. So associated with nausea, vomiting, diarrhea, tiredness, all these are initial symptoms that is associated with dengue. Again, another important point, most of our viral fever, whether it is H1N1 or a COVID or a dengue or a chikungunya, most of them, they present as vomiting and diarrhea. Why I'm stressing this is many times we confuse with acute gastroenteritis. So keep that in also mind. So sudden onset of high fever with other constitutional symptoms. So if you look into the temperature chart, it goes for around 3 to for almost 3.5 days, the temperature might persist. Why it is important? So please tell our patients that this fever will take 3 to 4 days to settle down. So keep giving paracetamol, adequate hydration. It will settle down, and also educate them on the warning symptoms, which I will tell later. So just look into the temperature chart. By fourth day or third, fourth day, temperature touches normal. Even it can go below normal, subnormal. So hypothermia can very rarely, very, very rare. So sometimes our patients can present with hypothermic shock also on the fourth. So this is a point Dr. Neminathan sir also stressing. Afebrile phase is very, very important, especially in dengue, because the patient might think he is better or he is recovering, but we have to tell them 48 hours minimum 48 hours after the fever touches. He has to be careful. He has to take complete rest, because that is a phase of complications. Already we discussed that not every patient is going to go for complication, maybe 5% or 10%, but who is that 5? Who is that 10%? Unless we monitor them, it's very difficult. Okay, so I'm not going to all the things as far as fever. So I'm just highlighting two important points: sudden onset of fever, and during afebrile phase, be careful. Next, this is most important in our practice. If somebody asks me what kills a patient in dengue, most important is dehydration. Of course, next would be plasma leak, and most important killer is the GI bleed. So these are the three important things that we have to keep it in mind. So why we are so worried about hydration in a case of, if all of us know there is no specific antiviral drug for a dengue. So what is the treatment for dengue? It is nothing but making sure patient hydration is maintained. Again, why there is dehydration? For example, high fever, vomiting, diarrhea, profuse sweating, patient not taking adequate fluids. So all these things can trigger dehydration. That is why please remember that not only for dengue fever, for any fever for that matter, and especially in dengue, make sure your patients are hydrated well. Best way to hydrate a patient is oral. Only if the need arises, for example, not able to take feeds, patient is drowsy, or patient is having continuous vomiting, only in those cases we can start with parenteral fluids. Otherwise, still the best way is oral. Coming back to the next component, for example, as I said, the second phase, that is a critical phase, starts after fourth or fifth day. So two important problems can occur. So one important problem is the plasma leak. So we call it as a third space fluid loss. This third space loss occurs in three important areas. One, especially in children, they can have periorbital edema. Especially in children, they can have a periorbital edema, number one. Number two is pleural effusion. So plasma leaks into the pleural space. Third thing will be the ascites, free fluid in the abdomen. So these are the three important areas plasma can leak during the critical, which may occur during the fourth or fifth day of the illness. And the final killer that kills a patient is the GI bleed. Again, we have seen dengue patients having, Sir was also mentioning about subconjunctival hemorrhage or mild gum bleed and all. But in dengue, those bleeds will not kill the patient. So the bleed that kills a patient in dengue is one, GI bleed. And next important bleed that we have to monitor, especially in women, is the menorrhagia. So keep these two things in our mind. So in our history also, so we have to ask them for any hematemesis, melena, and menorrhagia. It's a very, very important history that we have to keep it in mind. So friends, we are talking about zero mortality. So anyway, how many patients we manage, nobody will give credit. But even if you lose one patient due to dengue, it becomes a headlines in the media. So that's what I was repeatedly telling. What kills the patient is, of course, the bleed, and the patient slips into multi-organ dysfunction syndrome, what we call it as MODS. So if hydration is not taken care, if plasma leak is not recognized early, if the bleed is not managed properly, the patient will slip into multi-organ dysfunction. Then it becomes a very, very high mortality. Coming back to the last component, this is where our experience during the last 15 years has taught. Even during recovery phase, normally during recovery phase, somebody should not lose a life. But that we have seen sometimes in the field. why somebody is losing their life in the recovery phase because of fluid mismanagement. So that is where we say that we have to be very cautious in our parenteral fluid administration, and especially don't give more than 48 to 72 hours unless it is really needed. There's no need to give a fluid parenterally for more than 48 to 72 hours. So fluid overload, especially in children, pediatric practice, we have seen child dying due to overfluid and pulmonary edema like that, because the plasma which has leaked into the pleural space also enters the intravascular compartment, and the parenteral fluids that we are trying to push through the IV also causes fluid overload. So patient might be having a life-threatening complication. So this we have to keep it in mind. Just I'm trying to highlight the important components that we have to understand, so that these things we will keep it in mind when we are clinically approaching a case. Coming back to the laboratory, again, now whenever we say dengue, the next word that comes is the platelet. So let us understand it is not a platelet deficiency disease. We have treated even 0 platelets without platelet transfusion, or even we have seen platelets of 1 lakh coming with bleeding. So we have to understand, it's a very important point. We have to understand that there is quantitative as well as qualitative defects of platelets. Both we have seen in our practice. So as far as our management is concerned, most important laboratory investigation to assess the progression is hematocrit. Hematocrit, or the packed cell volume, is an important parameter that we have to monitor, where we say the normal hematocrit is around 35 to 40. So around 35 to 40. So anything more than 40 is always a danger sign. That is one criteria, or more than 20% from the baseline. Sab was also mentioning when to do a hemogram in a case of acute febrile illness. So I personally feel even maybe you can do it on 3rd day. If some cases are a high risk, even we don't mind doing on 2nd day, for simple reason, you will know the baseline value. You will know what is the baseline of packed cell volume or the platelets, so that when you are again repeating after 48 hours, it will give you a picture. So for practical reasons, more than 40 or more than 20% of baseline. Suppose if your baseline is 30, that means more than 20% means more than 6, that means 36. So in a baseline of 30, even more than 36 is significant. So that is another important point that we have to understand. And finally, we have to understand the diagnostic. Again, friends, I think everyone will agree that dengue or a dengue is a clinical diagnosis. Don't wait for any other report to come don't just watch the patient and with waiting for the report. Dengue, as we know, is a clinical diagnosis, and we are not going to give any antiviral if the report is positive or not. So practically sudden onset of fever with arthralgia, headache, vomiting, and with higher hematocrit or severe thrombocytopenia, maybe with plasma leak or with some bleed, we know I am dealing with dengue unless proved otherwise. So further investigation, especially ultrasound, we'll discuss about ultrasound later, where it is useful to pick up the gallbladder thickening. So as far as other investigations, it is only supportive, but for establishing a diagnosis, etiological diagnosis, we do 2 important tests. One is the NS1. NS1 stands for non-structural antigen. NS1 stands for non-structural antigen, which we have to do during the first 3 or 4 days of fever. Please do not do IgM during the early phase, because invariably it will be negative. Why I'm stressing, sometimes our patients will do IgM in the first 3 days, come back with a report saying, sir, dengue is negative. No. First phase or the early phase, we have to do only NS1. Maybe the IgM starts rising after 4th or 5th day. Keep it that in mind. Again, it persists. Your IgM can persist up to 3 months, up to 90 days. After that, it can disappear. But the IgG also starts rising. You can see in the picture, both IgM and IgG will start. But your IgG will persist for lifelong. That's a very, very important point. Again, we have to understand there are 4 sero subtypes, dengue 1, 2, 3, and 4. So if somebody gets dengue 2 in one, say at the age of 5 years, that particular child will not get again dengue 2. He may get 3, 4, or 1. So this is an important concept that we have to understand. And also secondary dengue. That means a patient who has a first dengue in the early phase, again another serotypes affects him later in his life. We call it as secondary dengue, which has got a much more complications and significant mortality. So these are the important, there are many things to be discussed in this slide, but just for understanding, just for day-to-day management, whatever I just said in this last 10, because I took almost 10 minutes to explain this slide, but that's very important. Once we understand these basic concepts and basic facts on dengue, it is easy to look into the management. So now we'll go into the profile of the dengue. I already said about asymptomatic and symptomatic. Again, for practical reasons, we can say symptomatic into mild, moderate, and severe. How to assess that, we'll go in a clinical examination. So again, we are talking about the warning symptoms and signs. This is very, very important because when a patient comes to our OPD, we should know what are the danger signs. For example, you can look into the slide. It talks about warning signs where they are mentioning about abdominal pain. Again, please remember, friends, abdominal pain is in dengue is an important danger sign because there are 4 or 5 reasons why a patient can develop abdominal pain. But the most important thing that we have to keep it in mind is the bleed. Suppose the patient is having a GI bleed, they can have an abdominal pain. Or because of acalculous cholecystitis, they can have abdominal pain. Because of tender hepatomegaly, they can have abdominal pain. Or progressive ascites, they can have. Maybe they could have taken some NSAIDs and drug-induced gastritis. But another important reason why a dengue patient can develop abdominal pain is due to bowel ischemia. That's a very, very danger because they can go for a bowel gangrene because of severe hypotension, bowel ischemia, which is very uncommon. But as far as day-to-day management, if a patient complains of abdominal pain, or even we have to ask whether he has got abdominal pain, be careful. We have to rule out. I'm not saying all abdominal pains are due to GA bleed, but we should not miss a GA bleed when a patient comes with abdominal pain. Again, the another word they're using is persistent vomiting. What we understand by word persistent, that means they say more than 3 times per day. If somebody is vomiting, we can take it as a persistent vomiting. Again, I mentioned about the fluid accumulation in the form of ascites or effusion, bleed. Again, initially I told about tiredness, fatigability. Again, ultrasound can show hepatomegaly. And laboratory, already I mentioned about significance of hematocrit and also the fall, rapid fall in platelet count. So these are the important warning signs. Why we are so worried about this? Whenever you are handling a patient in an OPD, when you know that patient is better, please educate them about this warning in their warning symptoms. For example, one more thing they say is patient not passing urine for more than 6 hours. Patient not passing for, it's an important sign. I'll discuss that in the clinical history. Yeah. So far we have just understood some basic facts. Now let me make it very simple. In our busy OPD, what are the quickly things that we are going to ask, what we are going to look, and what we are going to test. Again, I think the senior doctors will always appreciate asking and looking go parallelly. We need not do only asking one session and another 2 minutes for looking. As we talk to the patient, you look for the other symptoms and signs. So that makes our job quickly. We can assess the patient. So we ask for name, age, gender, again, address and contact number. It's a routine thing. Again, from public health, suppose if your patient becomes positive, you have to inform your local Deputy Director of Public Health. Any outbreak area, as today's topic is on monsoon. Already Tamil Nadu has seen monsoon has already set in a lot of, so any outbreak area, if it is there, it's important. Again, duration, grade, we have already discussed. Vomiting, diarrhea. Again, please remember, somebody can be constipated also. Why constipation? Because of fluid loss. they can have constipation. Again, I mentioned about bleeds. So ask for routinely, we have to, especially in menstruating women, ask for menorrhagia, because many people, they think it's a normal cycle. So they may not come out as a significant symptom. Aches and pains, lethargy, tiredness, again. So in our busy practice, I told you about urine output. So please ask one simple question. ஓபில வந்து உட்கார்றாரு, காலையில 10 மணிக்கு உட்கார, நீங்க கேஸ் பாக்குறீங்க, ஃபீவர் இருக்கா, தலைவலி இருக்கா, போன் பெயின் இருக்கா, எவ்ரிதிங், வாமிட்டிங் எல்லாம் கேட்டுட்டு இருக்கீங்க. ஜஸ்ட் ஆஸ்க் ஒன் இம்பார்ட்டன்ட் கொஸ்டின். கடைசியா எப்பப்பா யூரின் போனேன்? Whatever busy you are, whatever busy things you are having, please ask this one question. Or even you can ask your nurse, if somebody is there to help you, please ask them to routinely ask this question for any fever. கடைசியா எப்பப்பா யூரின் போனேன்? காலையில 10 மணிக்கு பாக்குறீங்க, பேஷண்ட் சேஸ், சார் நேத்து நைட்டு ஒரு 9 மணிக்கு யூரின் போனேன் சார், அப்புறமா நான் யூரினே போல. So he has not passed urine for more than 12 hours, almost 12 hours. Guideline says if somebody is not passed for more than 6 hours itself is a warning. Our person has not passed for more than, he may look absolutely normal, but he is in problem. So this is where in our busy practice, we have to identify the early symptoms and signs of people with suspected dengue who are all going for a problem. So one of the important thing is, I already mentioned about tiredness, fatigability, lethargy, not passing urine, bleeds. Or why I'm telling all these, they have all these things, definitely they have to be admitted and observed. Okay, coming back to the other coexisting illness, again, routinely for diabetes, hypertension, again, pregnancy. So again, guideline is very clear. Any pregnant woman with acute febrile illness should be admitted. Then what are the things you look for? Again, temperature, conscious, because once a patient is little bit hypotension, he'll be irritable. Don't ignore the irritability of a patient in our OPD. You may think he's making nuisance. No, he is irritable because of hypoperfusion, or it can be a manifestation of early encephalitis or meningitis. So don't ignore irritability in a patient. It's a very important symptom for us to look into what is causing that irritability. Again, hydration. I'll check about the capillary refilling time. I'm sure you can just check that. Again, as far as BP is concerned, narrowing of pulse pressure. Actually, since a time is short that I have to complete in maybe in another 10 minutes, I'll try to fast forward certain things that you can even check later, or maybe we can discuss in the question answer session. Pulse pressure. Narrowing.
Sir, excuse me, sir. Ramanandan, sir. You can take time, sir. You have another half an hour left. You can take a little longer time.
Oh, thank you. Thank you, sir. Thank you very much. Thank you. Okay. So as far as blood pressure is concerned, that is a very, very important parameter in our practice, especially for dengue. For example, narrowing, when I say narrowing of pulse pressure, suppose today I'm seeing a OP patient with 120/80, we'll assume. Same patient I'm advising to come back after 1 day or say after 2 days. So he comes next day, the BP is 110/90. We'll assume the staff nurse is taking the BP 110/90. He's walking into a clinic. Everybody will feel that he's okay. But just look at the BP, what was it there in the previous day? It is 120/80. That means the pulse pressure is 40. Today, 110/90, pulse pressure is 20. So failure to recognize. In fact, from our experience, if somebody asks me why we are losing some patient, not everybody, they're losing some patients since dengue. Personally, I would say it is failure to recognize the early symptoms and signs of complications. One of the early symptom and sign is your urine output. I mentioned about pulse pressure, narrowing of even in the morning, even if the patient is admitted. Sometimes we see the patient in OPD 120/80, patient is admitted in the ward, evening rounds 110/90. The person who has seen the BP in the morning is different and who has seen in the evening is different. So they have to always check whether pulse pressure is, how's a pulse pressure compared to the previous value. Then respiratory rate. So silent tachypnea. So in our wards, thus I'm sitting in the ward, somebody is just all right, but he's just tachypnea. Just the respiratory is 25, otherwise is fine. That is again the impending shock. Impending shock is first symptom will be your increase in the respiratory rate. Again, Sir was mentioning about jaundice. Okay, what is the relation of jaundice in dengue? Again, from our experience and from the textbooks, jaundice is not a common symptom in dengue. That's the first statement. But immediately somebody will say, no, sir, I have seen people with dengue and jaundice. Yes, you might have seen, it can. Think of a mixed infection. Whenever you are suspecting a dengue or clinically classical dengue with significant jaundice, because 30 to 40% of our dengue patients are having more than one infection. Again, this I have personally seen more than, especially in a tertiary care, you have seen even 3 in 1 patient, 3 in 1, that is dengue, lepto, and scrub. So like that, we have to always think that we have to suspect. So my next question would be, when will you suspect clinically in our busy OPD, when will you suspect more than one infection in an acute febrile illness? Don't wait for the lab alone. You can even clinically suspect. One, when the patient is having a significant jaundice in dengue, think of or rule out a mixed infection. Number 2, when a patient is having splenomegaly, because in a classical dengue, we normally expect tender hepatomegaly and rising of aminitis, OTPT will rise. Normally, we don't see. If you see again a spleen, for example, typhoid, yes, malaria, yes, scrub typhus, yes, lepto, yes, all these conditions are well known to cause splenomegaly. So that is another important thing. Similarly, third, when will you suspect? When you look at the blood report, whenever you are seeing a leukocytosis, normally in a dengue, we expect a leukopenia. But when you are getting a report, classical clinical dengue, but there is significant leukocytosis, possibility of a mixed infection. These are the few important clues that we can keep it in our mind. Again, capillary filling time. Please do this test, because especially in children, Dr. Neminathan, I'm sure will agree with me. That's a very simple, by touching the patient. I think the subsequent slides will tell you the five points that we can assess by touching the patient, especially in children. By just press the little finger for 5 seconds, then leave it. Normally, the thing should refill in 2 seconds. We give allowance 1 second extra, so the refilling should occur within 3 seconds. So that is a capillary refilling time. And if it takes more than 3 seconds, patient is in problem. Again, tourniquet test. Again, I'll tell you quickly. Check the blood pressure. Step 1. Step 2, take the average. For example, the BP is 120/80. The average of 120/80 is 100. So again, deflate the cuff, re-inflate the cuff to 100 millimeters, hold it for 5 minutes. Then I'll show I think next slide will show you how to look for that appearance of this petechiae over the cubital fossa. So you have to look at the purpuric spots. If the purpuric spot, after inflating to 100 millimeters, hold it for 5 minutes. Hold it for 5 minutes. Slowly deflate. As you deflate, you may see the appearance of purpuric spots, and more than 10 spots per square centimeter is significant. I think the picture will be able to explain it better. So always make sure your tourniquet test, especially when you're looking for a complication or a sick patient, is very, very important. Again, I already mentioned about rash that can appear over the face, abdomen, like that. Bleeding, mucosal bleed that can occur. Again, abdomen, hepatomegaly. Again, tenderness. I told you about the abdominal pain and epigastric tenderness. Always think of rule out a bleed. So these are the 5-in-1 maneuver. They say magic touch. Look at the color, capillary refill. By touching the patient, you know the warmth, whether patient is cold and shock, pulse volume, and pulse rate. So these are the things. They call it as a 5-in-1 maneuver. They call it as a mnemonic CCTVR. So again, sometimes you may see the rashes like this. So this is what I was mentioning about a tourniquet test. So you can see the small purpuric spot. This is a classical tourniquet test positive in this particular lady. So again, positive tourniquet test shows that patient is going for a capillary leak. So that's a very, very important test that will indirectly even tell you that patient is going for a problem, so that they need admission. So after getting a quick history and look at the patient, so the investigation is so much. But personally, I would say do a hemogram and especially the PCV. I already mentioned about the PCV and the platelet count. Don't worry too much on platelet count. So again, when we are discussing about management, I'll tell you when to give platelet transfusion, but the other test, whatever you see in the slide, it is mainly to rule out other possible differential diagnoses like malaria or the leptospira was mentioning about leptospirosis or the typhoid. So only one quick thing is, as far as antibody titers are concerned, we have to do after 1 week. So earlier, even Sir was mentioning about lepto. In the first 1 week, we have to do a dark field microscopy. That is the best test. Or if you want to do a typhoid test, you do a blood culture. That would be better than doing an antibody titer within 1 week. Again, presence of LFT will tell you the aminitis. I mentioned about aminitis. Similarly, I mentioned about jaundice. If the patient has significant 5 milligrams, 6 milligrams, think of any other co-infection also, especially like even viral hepatitis can be co-infection. Again, I want to stress about the ultrasound. I think this is a very, very important test, especially when the patient is complaining of abdominal pain or when the patient is having some symptoms and signs of complication. Your ultrasound will pick up early plasma leak, and also it will pick up the gallbladder wall thickening, and also it can suggest A calculus cholecystitis. So that is why, especially in our government general hospitals during these outbreaks and all, whenever a patient comes to the ward for admission, after checking the vitals and other things, after drawing the blood for investigation, routinely we do ultrasound. Even within 15 to 20 minutes of admission, we would have completed ultrasound, so that it will help us to triage. Suppose if I say a patient with significant plasma leak, I know we have to monitor much more carefully than the other people. So value of ultrasound is very much, especially when you want to triage a case or somebody is having a abdominal pain or shock, always you have to do an ultrasound that will help us to pick up the early plasma leak of effusion and ascites. Again, if you don't have ultrasound, at least do an X-ray chest. Okay. Now this is a very, very tricky question. Okay, doctor, I have a patient in front of me. I have to decide whether this patient can be sent home as outpatient or I should admit the patient. So again, the guidelines are very clear. Patient can be managed as outpatient if they are able to, one, take adequate volumes of oral fluids, because I already stressed that oral hydration is important. நிறைய வாட்டி நம்ம ஓபில பாத்தீங்கன்னா, சரிம்மா பாப்பா நல்லா தான் இருக்கு, தண்ணி மட்டும் நிறைய குடி, இந்த ORS குடுங்க. என்ன டாக்டர், ஒரு முழுங்கு தண்ணி குடிச்சாலே பாப்பா வாமிட் பண்ணுது, ஒரு முழுங்கு கூட குடிக்க மாட்டேங்குது. That means you cannot manage as outpatient. So when the patient is not taking oral fluids, or when the child is too tired, fatigability, I already mentioned about the warning symptoms. So if they have, please admit. Again, next question comes, why we are admitting? That's the next question. Why we are admitting? One, close monitoring, continuous monitoring, and correct monitoring, which we cannot do when the patient goes home. Of course, parenteral fluids can be started if the patient is admitted. So I'll put the statement in a different way. We are admitting not only for parenteral fluids. Not every IP needs IV also, fluids also. So the purpose of putting a patient as an inpatient is for monitoring, and if need arise, for parenteral fluid management. So already I mentioned about the, again, patient is passing urine and patient do not have the following signs, which I already discussed. So if they do not have, okay, காலையில 10 மணிக்கு பேஷண்ட் வந்துச்சு, நீங்க பாக்குறீங்க, ஒரு 1 hour 2 hours பாக்குறீங்க, child is okay, you can jolly well tell the patient to go and come back later. But நம்ம இன்ஃபேக்ட் நம்ம அந்த ட்ரைனிங் ப்ரோக்ராம்ல என்ன சொல்லுவோம், ஒரு சார்ட்டே ஒன்று போட்டுல நம்ம கிளினிக்ல, கீழ்கண்ட அறிகுறிகள் இருந்தால் உடனே அருகில் உள்ள மருத்துவமனைக்கு அழைத்து வரவும், தொடர் வாந்தி, வயிற்று வலி, ரத்தப்போக்கு, 6 மணிக்கு மேல் சிறுநீர் கழிக்காமல் இருத்தல். பிகாஸ் நம்ம 10 மணி 12 மணிக்கு பாப்பா நல்லா இருக்கும், ஆனா வீட்டுக்கு போய் சாயந்தரம் 6 மணி 7 மணிக்கு எப்படி இருக்கும்னு nobody can predict. So we have to tell the attenders or the patient, if you have anyone, please come immediately. Okay, so what is the advice at home? Complete bed rest, adequate fluids. Again, paracetamol, best way to give paracetamol is oral or suppositories. Avoid IM. Generally, we say avoid IM injections. Maybe you can now IV para is freely available. You can try IV paracetamol, or as an outpatient, best is suppositories are also available. So depending on kind, tip-pit sponging, I think recently there are some papers that avoid tip-pit sponging. Again, I leave it to the practitioners. Maybe if time permits, I personally feel there's no harm in doing it, but maybe Dr. Neminathan will say about different views recently reported later. Again, check for the breeding and around, and also educate them on the symptoms. Okay, I already said when to admit. When the patient has any symptoms and signs of complication, admit. Or, as I already said, pregnant women, all pregnant women, children, or old age, not 65, 70, they cannot come back in emergency, or with comorbids, especially obesity. Again, interestingly, obesity has become a risk factor for infectious disease also. We have seen during COVID, during H1N1, during dengue, obesity itself is high risk for any complications. So we have to admit them. So this is a very interesting chart that we have to maintain once you are admitted. But I think this talk focuses more on OP management, but no harm in just once you are admitting also. Maybe even you can admit for 6 hours, 8 hours and observe. There's no harm in that. Look at the temperature chart and respiratory, all these things are. Only one thing is missing in this chart, that is the urine output. Make sure that your urine output also is maintained every 4th hourly, like that, so that we can closely, as I said, I always believe if you want to reduce the mortality or achieve zero mortality, we need a close monitoring, we need a continuous monitoring, and we need a correct monitoring. Again, we don't need a multi-para monitor. It's all the checklist what I have projected is a clinical. So if even a good nurse can do all these parameters, but it should be a correct parameter. So these are some of the pictures that we managed in our, you can see the hydration, you can see the nurses going in because we kept the ORS in a corner and nobody knew where it was and nobody even went near that. Then only our Dean Madam suggested, instead of people coming towards ORS, let the ORS go to every bed. So it has made a good impact on the recovery. Again, everybody is given, and also they're checking the temperature. They're talking about urine output and also rice. Again, one of the good hydrating fluid is rice kanji, apart from ORS and tender coconut and other things. So they are giving this. Again, monitoring. I was mentioning about close, continuous, and correct monitoring. Again, we had a lab inside the ward itself. Again, the value of ultrasound and value of bedside lab, already I have stressed the importance. Okay, now how to classify these patients? As I said, we can mild, moderate, and severe. You can just look into the thing. Any patient under group A can be managed as outpatients, but adequately informing them about the symptoms and signs of complications. Group B, definitely they need admission, maybe in general ward, but anybody who was found group C symptoms like severe shock, respiratory distress, bleeding with early multi-organ dysfunction, definitely they have to be managed in ICU. So this is a very, very important slide to just to know that it's a dynamic disease. I say always that dengue is a dynamic disease. I think people who have handled many dengue patients will also agree. Silawati patient nadandu varuva. That is what problem. Inna sir patient nadandu vanda admit panna kaalaila ipo irandu potan solringla neenga enna panninga. They will always ask. So we call it as walking shock. A patient in dengue shock even can walk into our clinic. So just by looking at the patient, we never assess the severity of the issues unless we check the parameters. So this slide talks about, say, patient may look stable. So within few hours, he may develop warning signs. Again, if those signs are not recognized, if the signs are not treated, they go for a stage of compensated shock, that is walking shock. And in maybe hours or even few minutes, they go into a sudden collapse and they go for a sudden cardiac arrest. So many times we have seen they go to the toilet, collapse and have an arrest. So this is where what we call it as from compensation to decompensation is a very quick transition, can occur within 12 to 24 hours. So that is where our monitoring makes very, very important. So when we come to the most important part of my talk regarding the management of fluids, so we always call it as a rescue phase, especially when the patient comes in shock. Then they go into optimization phase. then stabilization phase, then slowly we try to stop, what we call it as a de-escalation phase. So as I said, when a patient comes in shock, we'll go to the fluid protocol, then slowly try to adjust, then finally we have to stop that. So if you look into this, again, whatever we talk about, so rescue means patient comes in shock, it's a life-saving, and we have to give a rapid bolus. So just when a patient comes in a shock, we have to start with a bolus of 10 to 20 ml of kg, as a best fluid to start is normal saline. So avoid or even don't give 5D. Please don't start 5% dextrose in any dehydrated state. Always normal saline. And regarding oral, yes, it can be tried, but it has some limitations. So in a simple practice, I personally recommend NS, normal saline, is the best for 10 to 20 ml per kg. Again, you give it over 15 to 30 minutes. Once a BP is peaking, so for example, patient comes with say BP of 80/60 like that, you need to give a bolus. Sometimes we start 2 IV lines in both limbs. So this is where the role of primary care doctors is very, very important. Sometimes patient might come to you in a stage of shock at the primary care. Don't panic and don't simply refer the patient without resuscitating the patient. The shifting time of shifting time of even 30 minutes can decide the reversible to irreversible shock. Then after fluid starts going, then titrate the fluid and make it as around 5 to ml. And once a patient is stabilized, just you can give adequate maintenance, maybe 3 ml per kg. And maybe once a patient is conscious, patient is taking oral feeds, you can even stop these fluid requirements. I'll try to share the slides of fluid management so that you can also look into it lightly. Again, this talks about you start with a 10 ml here and slowly try to stop after 48 hours. And again, whenever the patient can take oral fluids, always calculate the oral fluids, and whatever is deficit, you can substitute with your parenteral fluids. Again, these are the charts as per the WHO recommendation and Government of India recommendation. So whatever I have said, it talks about in how to monitor when you're giving fluids, what is the best parameter to know whether your fluids are adequate. One is urine output, next is hematocrit. I always say hemo concentration. So if you see a hematocrit of 45, even we have seen 60, 65, that means severe hemo concentration. Maybe we have to give a high fluid, parenteral fluid, so that the hemo concentration is taken care. But a patient with say 45 of hematocrit, suddenly the hematocrit comes down to 30, always think of a bleed. Sudden fall in hematocrit also is not good. We expect the hematocrit come slowly. I'll try to finish in 2 or 3 minutes, sir. So all these patients, when you see a severe, already I told about CAT-C, they need immediate resuscitation and to be admitted in ICU setup. Again, talking about temperature control, again, oral or infrafluids, I already mentioned. Regarding blood transfusion, if the patient is losing blood, please give blood. Again, always go for a fresh blood. Don't worry about platelets. If the platelet, again, guideline says the platelet is less than 20,000 in adult or even less than 10 in children, you can go for a platelet transfusion. Otherwise, we can, as long as there is no bleed, we will not worry too much of platelets. 40,000, 50,000, don't get panic if there is no bleed. But if there is a bleed, please try to go for a whole blood or Paxil. Paxil volume, the guideline says 10 ml per kg. For whole blood, if it is going to be Paxil, it is 5 ml per kg. So sometimes we are not going to the complicated dengue in this forum. Sometimes they go for a persistent hypotension because of septic shock, myocardial dysfunction, or occult thing. They may need a inotropic and other support. So these are the indications for blood transfusion. Again, avoid all these NSAIDs, aspirin, steroids. Again, when we're talking before COVID and all, we always say steroids don't give, but COVID has taught some new lessons also. Again, we have seen COVID and dengue also, but not that much in Tamil Nadu, because we have gone through the statistics, not so common, but we have seen in other states in northern, the combination was significant. So these are the various differential diagnoses that we have to keep it in mind. So all these things. So always keep this in our differential diagnosis. So I'm not going to the scrub typhus, but to conclude, what I wanted to tell is dengue is a self-limiting diagnosis. It's acute viral disease, but it can trigger complications in 5 to 10% of the population. The most important challenge is dehydration, plasma leak, and hemorrhage, which can be easily picked up clinically, confirmed by laboratory or ultrasound investigation. Management includes take care of the symptomatic and supportive, make sure hydration is ensured. Patient is watched for any bleeding or plasma leak. If need arise, give platelet transfusion or plasma. I mean, sometimes we do give plasma also, but if the bleed is significant, give whole blood or Paxil. Make sure the urine output is maintained, and early referral. If the patient goes for any complications like whatever I mentioned, refer the patient to a medical college or a tertiary care hospital where he can be managed. Once a patient slips into organ dysfunction, mortality. So referring to a tertiary care after multi-organ dysfunction is not going to help the patient. So I request the primary care physicians who are going to handle this paper, closely watch, educate them on the warning symptoms and signs, promote hydration, have a follow-up, and be careful about the afebrile phase where the patient is going to go for complications. So I'll just stop here. Once again, I thank the organizers for this opportunity. And if any questions is being asked, definitely we'll try to answer. If can be, I could answer. Thank you very much.
Thank you, sir, for your nice lecture.
Thank you very much, sir.
Thank you.
Sir, it was highly informative and useful. I'm sure all the doctors must have enjoyed your lecture. Sir, you can exit, sir. You can exit the slide.
Yes.
If there are any questions, please post in the chat box. At the end of the meeting, we'll friends, once again, I'd like to thank the IMA CGP, Dr. Sengutu sir, Dr. Sendil Rajkumar and the team for giving us this opportunity. Now you have heard both leptospirosis and dengue, and next is my friend Dr. Suresh Kumar from infectious disease consultant from Apollo Hospital, Chennai, who is going to deliver on scrub typhus. Before that, I like to once again invite you all the delegates. More than 1,000 people are there, 1,000 doctors. So we have an IMA Tamil Nadu State CGP wing as an infectious disease certificate course. It's a 6 months online course. The course has just started now. Only hardly 1 or 2 classes have been over. Those who are interested, please can join the course. You can contact Dr. Sendil Pollachi, IMA CGP Secretary, or Dr. Sengutu sir, the chairman, or you can contact me, Dr. Neminathan, in my number 984221179. The certificate course is just started and you can join. It will be very, very useful for your day-to-day practice. It's a very, very friendly course in which you gain lots of up-to-date knowledge about infectious disease. That's going to be very useful trend changer in your day-to-day practice. Those who are joining late now, you will get the previous classes through your already recorded programs will be given to you. And so those who are interested in joining this infectious disease certificate course, please contact me in this number 984221179. And also, if you want the slides of this CME, you can contact me through this number. With this, I once again request all of you to stay back, enjoy learning. May I request Dr. Suresh Kumar to share your slides. Dr. Suresh, please start sharing your slides. Yeah, your slides are visible, Dr. Suresh.
I need to put it in the F5.
Yeah, you are slightly raise your volume. You need to, your volume is.
I see.
Yeah.
I hope my slides are visible and I'm audible.
Yeah, you are clearly visible and you are definitely audible. Okay. And may I have a minute of yours? I like to introduce Dr. Suresh Kumar, who is an MD, FND in infectious disease. He is a co-founder of one of the best IDs, that is to treat, teach, and transform infectious disease. He is a senior consultant of infectious disease at Apollo Hospitals in Chennai, and he is my friend, close friend. And also, I admire him for his academic excellence. He is always a preacher of antibiotic stewardship. So in future, we'll be having lots of programs related to antibiotic stewardship. In our infectious disease certificate course, Suresh is going to give us a lecture about how to prescribe antibiotic. That is, he is going to tell us about the 4 Ds, the correct drug, the correct dose, the correct duration, and when to de-escalate, when to stop antibiotics. All these secrets he is going to tell us. Those who are interested in knowing about the commonest drug that we use in our infectious disease practice, that is in our day-to-day OPD, you can get lots of knowledge, particularly on various diseases, how to make a correct diagnosis, how to choose the correct drug, and how to investigate the child properly. All these aspects will be discussed in our infectious disease. He is also an active contributor, one of the faculties of our infectious disease certificate course. With these few words, may I hand over the mic to Dr. Suresh Kumar. Now the stage is yours. Suresh Kumar, welcome.
Thank you, sir. Thanks for the kind words of introductions. I sincerely thank IMA CGP Wing for giving this wonderful opportunity. I know I'm the last speaker. People want to practice at 6 o'clock. Your OP may start, but I'll keep my presentation short as well as sweet for you so that you can shoot a lot of questions towards the end of my presentations. So before the disclosures, we are infectious disease doctor, as rightly pointed by chairperson. So we need to know selection is a bit difficult. But as far as the scrub typhus is concerned, there is no major challenges for you. This is challenges for antibiotics only, not for the scrub typhus. So my objective today is what is the definitions of a scrub typhus? What is the epidemiology is going around? What are all the clinical features and what is the differential diagnosis you need to think about? How to make the laboratory diagnosis, how to manage. I'll try to summarize at the end in another 15-20 minutes and you can shoot a lot of questions to me there. So before that, lot of rickettsial infection is going on. If you see the rickettsial infection, spotted fever, typhus group, scrub typhus group, other related illnesses. But my focus is today's scrub typhus because other things like spotted fevers are a bit less. Typhus group we rarely see. Other related illness like Bartonella we can use to see, and Q fever, some of the endocarditis we encounter. My focus is today's scrub typhus. I'm not discussing with the case here because you see a lot of theory. I'm putting a case here. This is a 45-year-old female housewife from Vellore. She got fever of 10 days durations. I like the participants can please go ahead and put it in the chat column so that we can know there are more than 1,000 participants. How many are actively participating in the quiz? I just want to check. So this is a 45-year-old female housewife from Vellore, fever of 10 days durations. She got headache, body pain, nausea, and vomiting. On examination, she is febrile. Rales were present. Few cervical nodes were palpable. What is your diagnosis? Since the talk is a scrub typhus, people want to say this is a scrub typhus. Clinically, I make a diagnosis of probable scrub or confirmed scrub or any of the above. Because this is a scrub typhus talk, it won't be a scrub typhus bioid. So please go ahead and put it in a chat column so that we can have a discussions at the end. Not calling it, but just put it in a chat column so that we can discuss and we can see how many people are active. I think so many responses I start seeing there. So almost 20-25 responses happening. That's a very good sign. Of 902 people, almost 25 to 30 actively participating. That's a good sign. Good. So when to call a definitions? So this is a clinical definitions. When a fever has got acute undifferentiated fever, and the patient has got fever, headache, body pain, and the patient is lasting for more than 7 days or more than 5 days, you can keep. When a fever lasting more than 5 days, why this 5 days? Most of the viral fever by this time subside. For example, the previous speaker alluded about dengue. The fever lasting more than 5 days, I don't put my money on dengue. The chances of dengue more than 5 days is little less likely to me. So any undifferentiated fever that lasts more than 5 days with or without HCAR, but presence of HCAR, not even 5 days. Even on day 3, if you are able to notice some HCAR, I'll come back and show what is HCAR. I'll show some pictures also. If you see the HCAR, even 3 days, that is required for making a diagnosis of it. Other presenting features like headache, rash, but populations like India, the rash is very difficult to notice down. The erythematous rash we can able to see, but dengue has got more rash compared to scrub typhus, but lymphadenopathy can present. So the hallmark of scrub typhus is acute undifferentiated fever, headache, body pain. Lymph node may present or may not present, but HCAR is a classic thing, but don't expect HCAR in all cases of scrub typhus. That's more important. When to call probable scrub typhus? That is clinical scrub typhus. As a clinician, when you see in the OP, these things is come across, you can put your money on scrub typhus. But if you want to confirm the diagnosis, people do 2 ways. One is called the wheel Felix. But unfortunately, wheel Felix has got a lot of cross reactivity. It lacks specificity. What is available now? Scrub typhus, IgM ELISA. That is more important. But people doing on day 2, day 3 of the fever, all serological tests we need to do after day 5, because body should recognize the pathogen and produce an antibody that requires minimum 5 days. So don't do any serological test between day 0 to day 5. That is why I'm telling it. Most of the time, scrub typhus is a clinical diagnosis. It's not a laboratory-based diagnosis. Why? One, the IgM ELISA is not available. Field Felix is available, but a lot of false positivity can happen. Third thing, we need to wait for 5 days. And PCR is a gold standard. Unfortunately, PCR is not available even for the tertiary care hospitals. So I'm coming back to me, how to confirm the scrub typhus. We need to go with the PCR. Ideally, from the HCAR or from the blood also we can do. Very few centers do the PCR. For example, CNC Velo has got started, but of late, a lot of commercial PCR is also available. If you want to make a diagnosis of scrub typhus 100%, we need to do the PCR. So that's a gold standard. So these are the key definitions for the scrub typhus. One is clinical, second thing is probable, third thing is definite. Clinical, any fever lasting more than 5 days, and the patient is from epidemiological background, along with headache, body pain, and the presence or minus of HCAR. Even with HCAR, not even 5 days is required. Probable diagnosis, presence of clinical features along with IgM ELISA. When to call confirmed ELISA, confirmed scrub typhus along with PCR positivity, or if you're able to culture it, that's fine. But culture is very tedious process, very difficult to do it. So this is the definitions according to the guidelines, what is written. Most of the time we are making clinical diagnosis rather than go by probable or confirmatory test. This is what we are doing it now. So what is a epidemiology? Where is the scrub typhus? This organism is an intracellular gram-negative organism. It's an obligate intracellular organisms. That is why it is very difficult to group. All the organisms is obligate intracellular is very difficult to group. What is a reservoir? This is a larval stage of the mite. This is not the adult stage of a mite. This is a larval stage of the mite. Humans are the intermediate host, not a definite host for us. We are an accidental host. Infection is transmitted through the bite or the mite. Usually the bite is a painless. So the patient cannot tell the history, I got a bite. I got a pain at the bite site. They cannot tell. So it's a painless bite. That's the most important thing. That is why the HCAR also will come back, will explain why the HCAR is seen in different places. The incubation period average is 10 to 12 days, but it varies anywhere between 1 week to 3 weeks, 7 days to 21 days. It's not communicable from person to person. Usually in the month of seasons or then monsoon season, it's quite common. For example, in the month of August to February, it is quite common. That's his common period. This is an epidemiology. I'll see the presentations. Lot of reports. If you see before 2009 or 2010, scrub typhus is hardly seen. Mostly typhoid, malaria, dengue. But after 2008, 2009, a lot of literature is coming up. Why? The awareness has gone up. Like IMA CGP is conducting a program now. Similarly, so many organizations conducted, they created awareness. So previously, the general physician, they thought only malaria, dengue, typhoid, leptospirosis. They not talked about scrub typhus. But now the entity of scrub typhus has come thanks to the IMA CGP, thanks to Dr. Neminathan, Dr. Raghunandan sir. Most of the people, they thought this type of awareness has been created. So where is the belt? This is called the Susugumeshi triangle. Previously, this is called Susugumeshi, but now it's Oriental Susugumeshi, we call it there. So this belt is called Asian belt. Ideally, where a lot of monsoons, a lot of water exposures, a lot of epidemiological exposures happening in this area, where a lot of agricultural activities happening, we can able to get it. Because the mite likes usually requires shrub areas and bushy areas where it goes and hide it. So this is an area, particularly the area belt I have shown. This is a typical Susugumeshi triangle there. And this is a beautiful picture in BMJ. If you see what are all the things you can see in Southeast Asia, depending upon the different continents, they put what is the number 1, number 2. But they still put malaria in Southeast Asia, but malaria numbers is going down as far as Chennai is concerned, as far as Tamil Nadu is concerned. I have not seen malaria that much. But we are seeing endemic fever cases, yes. And we are seeing a lot of rickettsial illnesses. Particularly the commonest rickettsial illness I'm seeing is scrub typhus is the commonest rickettsial I'm seeing. Similarly, leptospirosis, my previous speakers alluded how the leptospirosis. But what is emerging? Dengue is emerging more. Last 2 years, COVID, even influenza stages we start seeing. So these are all the cases I'm looking at it now. So in India, where it is common, previously it is in a suburban, it is a rural disease. It's a rural disease, but now it's migrated to urban. In fact, I remember in 2008, my first cases of scrub typhus diagnosis I made, the person was belonging to city. He was living a lawyer in Mylapore. I told him where you're living. He's living in a proper flat. Where is the exposure to the mite? I was wondering. In fact, we visited the house also to find out any exposures. Then finally, when we dig the history, he used to go for a morning walk and he used to sit in the park in the lawn. He's not sit in the bench. He used to sit in the lawn after the morning walk. So there he got the bush bite, the bite or the larval bite happened in the park area. So even though he's living in a flat, chances of getting strep typhus is unlikely. So we need to ask a good, proper epidemiological history. What are you doing? Where you have traveled? What sort of activities you are doing? That gave the clue to me to make a first diagnosis. So first thing is living in endemic area. Endemic area means I show the triangle, but India, almost all the states has reported. Previously, some of southern states, Himachal Pradesh, but allowed almost all the states as reporting now. So what is engaging in? People do agricultural type of jobs like tea plantations, vegetable fields, farm work, working in them with the short sleeves. People are using short sleeves, not exposing the bodies. So these are all the activities exposes a person to the strep typhus. Then what is a pathogenesis? Once the mite is bite you, it inoculated the skin. Then it invades the local lymph nodes, then goes through the bloodstream and causes vascular endothelium, basically causes a systemic symptoms in the form of hyperemia as well as lymphadenopathy, like vasculitis like manifestation. That is why the eschar is happening. So from the bite side, taken by the lymphatics, taken by the vascular systems, causing the vasculitis like picture. That is the reason for these presentations. Then what else? I'm showing, coming back to my case. So what do you think? Does this patient has got strep typhus? Because there is no eschar I so far shown. Only I told the patient has got fever, headache, body pain. But according to the ICMR criteria, any fever, undifferentiated fever, more than 5 days, headache and body pain, that is called clinical strep typhus. This is possible. One of the differential diagnosis, but not a different diagnosis, but differential diagnosis we can consider. So these are all the clinical features. People always want to know what is a eschar. The number of eschars cannot be seen in all cases. Eschar can seen oddly 50 to 60%. In our data, we publish a large number of trials, large number of cases. It's shown 67% of the cases. It's shown 67% of the cases. Eschar is present. Not all cases it is present. That's most important thing. Usually it happens between day 5 to day 7. That is the time it is going to happen. Then the beautiful part, where the eschar to see. Because I told the patient is not going to complain, I got a bite, I got a pain, I got a skin rash, they cannot reveal. We need to ask, is there any black spot in your body? Black 25 size coin in the body. We need to ask, where to look, where to look. So where to look, this is a point we need to look. Either the patient should have in the axilla, armpit, where females has got more in the armpit region, males most in the groin region. Why? They wear a tight garment. The larva will go up, where the moisture is present, it will bite at the moisture area. So females wear the upper garments, tight garments in the upper part of the body. So in the breast or axilla region, we need to see in the female. Where the males wear the tight garments, below the umbilicus. So we need to examine below the umbilicus. So always strip the patients, examine the patients. If you strip and examine the patients, you know the eschar. Once you see the eschar, there is no need for any blood test. There is no need for any serology, no need for PCR. We need to start straight away treating. This is a beautiful eschar I'm seeing here. So this is the area groin. This is a male. So if you see the groin area, black necrotic area surrounded by hyperemic region. So necrotic area, hyperemic. Usually the lesion is only one. But sometimes we have seen as in tertiary care hospitals, we have seen multiple eschars also, but that is not a rule. The rule is only one eschar, black necrotic center surrounded by a beautiful erythema, usually in the groin in case of male, the case of axilla breast in the case of female. But don't think this is the diagnosis for. That's why I said eschar will support. But other things like spider bite, Mediterranean spotted fever, African spotted, even fungal infections like fusariasis and mucormycosis can behave this way. So once you saw an eschar, don't put your money straight away into the strep typhus. So what are all the severe manifestations? It can affect any organs. It can affect lung, it can affect brain, it can affect lung also. We have seen a lot of meningoencephalitis with strep typhus. That is why any meningoencephalitis, people adding doxycycline as a therapy. Similarly, for acute ARDS, during the time of COVID, people always put money on ARDS, but we have seen strep typhus also. Similarly, any organ injury, acute kidney injury, don't think leptospirosis can affect the kidney. Strep typhus also affect the kidney. Keep in mind, these are all the differential diagnosis, any organ failure. So what is the bottom line? You don't see the strep typhus patients and not only in OP, not only in the ward, you can see the patients in ICU also. That's the bottom line I'm making here. And this is again a beautiful chart from BMJ. If you see rash, particularly the eschar is classic, lymphadenopathy is present, fever and shortness of breath, altered mental status, all are common with strep typhus. So I seen in the red column, ICU patients, blue column, and the patient is in OP or ward. So what is a stool? People want to do some simple scoring system. For example, people above the age of 65, recent field work, particularly agricultural job, onset of illness during the monsoon period, myalgia, escar. But all this scoring system, it has got good negative predictive value. If all the things is not there, we can rule out scrub typhus. But most of the time, the patient might have myalgia, some fever, body pain. It's very difficult for using the scoring system. But only the scoring system has got good negative predictive value to rule out escar, to rule out scrub typhus. So this is a laboratory. Who to suspect scrub typhus? The WBC count should be elevated. Platelet count will be a bit low. If you do an LFT test, alkaline phosphatase, GGTP elevated along with mild SGOT, SGP. That's called mixed pattern. Both hepatocellular as well as cholestasis can present. Wheel Felix is used as test because it lacks sensitivity and specificity. Scrub IgM ELISA after day 5 to day 7, it has got meaning. Before day 5, it has got roll. Keep in mind. So Wheel Felix is not, we are doing it because the sensitivity and specificity is very poor. Sensitivity is even poor. Specificity is okay, but some cross reactions can happen. IgM ELISA is a good test. Unfortunately, the immunofluorescence as well as PCR is not available freely. If you are able to get it, that's a gold standard for you to make the diagnosis of scrub typhus. So what I am doing when a patient is coming from the suburban area or patient exposed to some bushy areas and do some agricultural job, exposure history is present, fever, headache, along with able to see the escar, you can put your money on diagnosis of scrub typhus and start treating it. I don't want any basic investigations. So take proper history, do proper examination. That is more important. So what we need to do, coming back to this case, does this patient recover? People always want to know, once you made a diagnosis, they will ask you questions because she now shortness of breath. She become hypotensive. The urine output, she started doing signs of multi-organ dysfunctions. So don't think scrub typhus is not going to cause the multi-organ dysfunction. That's why I'm saying a lot of ICU patients also I'm seeing. Right now, she came with the OP sittings, admitted in the ward, but right now she's seeing in the ICU with multi-organ dysfunctions. What will you do now? People ask, what is the prognosis? So how to prognosticate? Mortality is 0% to 30%. Of late, the mortality is coming down. Why? The awareness is high among the physicians. So the awareness is very high. People are starting doxycycline or azithromycin. That saves a lot of lives to be there. So this is a predictor. When the patient has got hypotensions, elevated kidney functions, altered CNS dysfunctions, bilirubin elevated, or ventilator support, the prognosis is bad. So usually this is a signs of organ failure. When organ failure happens, the patient's making chances of going back home is a bit low. So we need to know the prediction. What is the D treatment? Scrub typhus and leptospirosis or doxycycline deficient state to be there. So usually we need to, when we're not making a diagnosis, we are not able to get a clue, one antibiotic, but after day 5 to day 7, don't before day 5. You made some diagnosis like dengue, there's no need for antibiotics. Suppose you're not making a diagnosis, ideal thing is azithromycin to me because it covered typhoid, it covered leptospirosis, it covers scrub typhus too. So the definite treatment without send the test, but don't wait for the test. Suppose a patient presents me to day 3, day 4 with escar, classic presentations. I need to start an antibiotic based upon my suspicion of scrub typhus. So based upon the suspicions, so what are all the drugs available? Usually we use 2 drugs, either doxy or azithromycin. Ideally, azithro is good because it is a broad one. It covered typhoid, it covered leptospirosis. When we do not know exact diagnosis, use azithromycin. When we know the diagnosis, use doxycycline. But there is no major differences between doxy and azithro. People want to know ICU patients what to start. One recent paper in NEGM published from CMC Velo, it shows IV doxy plus IV azithro for a couple of days initially as a combination therapy, better outcome. But that paper has got a lot of criticism. That's why I didn't put the paper. Usually, we prefer one drug, either azithro or doxy. I don't want to combine both the things. Even for a sick patient, if you start one drug, that is fine. The patient is not able to take orally, start IV. That's my principle. If you see the chart, there is no differences between doxy and azithromycin. That is why I'm suggesting one is fine. There is no major differences in the outcome. Only one day with the doxycycline, the fever settled down a little earlier. Compared to azithromycin, one day earlier can happen. How to prevent scrub typhus? Ideally, we need to avoid the mite or the larva. So how to avoid it? Wear a full sleeves, avoid exposure to the bushy areas. If you're wearing a bushy areas, we need to wear full sleeve and we need to check any bite happened or not. Sometimes we can dig out the larva also. So wearing your clothes, change or washing the clothes, taking showers after visiting these areas. These are all the prevention areas we can do. So in summary, scrub typhus is a re-emerging disease. Not re-emerge, already it's emerged to be there. It should be considered any acute febrile illness that lasts more than 5 to 7 days from a suburban area or people visiting the bushy areas and doing agricultural job. escar nearly confirms it. elevated WBC count and low platelet, mixed pattern of liver enzymes, elevated alkaline phosphatase, OTPT, scrub IgM ELISA after 5 days, doxy or acitro. For pregnant women, we can give rifampicin also. So nobody should die of tropical diseases. Rather than what we need to do, there are 5 mantras. Most of the fever, tropical countries, less than 5 days, fever subside, mostly viral fever. Don't bother about it. But you take proper history. Try to localize any particular organ is affected. For example, urinary tract infections, pneumonia. So don't always confuse your tropical infections with the syndromes, meningitis, pneumonia, UTI. Think about
Duty
it.
doctor could eat what's here.
Proper physical
Duty
exam,
doctor, patient question, duty doctor.
proper history.
Duty doctor patient duty doctor.
That's what we need to do. If you take a proper history, do a proper examinations, you can get the clue. And these are all the simple things. Dengue means sharp onset of fever. Usually the fever lasts for 3 to 5 days. After fever subsiding, some abdominal discomfort. Malaria, we are not seeing the classic intermittent fever, chills and regulars no more existing. Typhoid, young people eating outside food, fever lasting more than 7 days. Leptospirosis, walking in the rainwater, wading in the rainwater, swimming, hiking, these things should happen. Scrub typhus, again, bushy area exposure, think about it. So how to check malaria? Always do by peripheral smear or QBC. Scrub typhus, clinical diagnosis most of the time. If you got access to IgM ELISA, after day 5, you can do it. Leptospirosis, again, clinical diagnosis. If you got access to the PCR, right now PCR is available in Chennai, we can able to do. Dengue, CBC, with the LFT, we can able to tell, or NS1 antigen on day 1 to day 2, IgM from day 4 to day 5. So these are all the things. And for example, with the WBC count, hemoglobin elevated, think of dengue. Hemoglobin low, malaria. Total count normal or low, think of typhoid versus dengue. Total count elevated, leptospirosis versus scrub typhus. More of cholestasis, lepto or scrub. More of hepatocellular pattern, dengue or typhoid. So this is a simple things you can keep in mind and know the timeline. Any fever that causes more than 7 days, don't put your money on viral fever, particularly dengue fever. So this is a beautiful things. What are all the tests we need to do? Again, from same the BMG infographics, BMG infographics, use the BMG infographics for yourself. So for example, what we need to do for scrub typhus clearly shown, IgM ELISA or clinical diagnosis is possible. Treatment, malaria, chloroquine for Vivax. For falciparum, we are using artemisinin-based combination therapy. Typhoid, anything is fine except fluoroquinolone. Scrub typhus, either doxy or acitro, avoid cephalosporins. Leptospirosis, all are equal. Dengue, only symptomatic care. That's what we need to do. So malaria start diving on scrub typhus, people start looking at it. Already IMA CGP started. We are also conducting one virtual fellowship course from August onwards. Those who want to join this one, this has got more of hands-on and more of ID related stuff. Not a tropical stuff, more of ID related stuff. Anybody want to call? I given my number to contact also. This is virtual fellowships again starting on it. So please feel free to contact. This has got a lot of hands-on training. Those who want to learn practical ID also, feel free to contact us. We can round with us. For example, the fellows joining IMA CGP, if you want to learn practically, I am happy to provide practical hands-on training to them. Thank you for the wonderful opportunity given by IMA CGP. Hope we can have some time for discussions.
Thank you, Dr. Suresh Kumar. Thank you. You can unmute yourself. Thank you, Dr. Suresh Kumar. It was an excellent talk. You gave all the valid points for the practitioners about the scrub typhus. It was really thought-provoking, and it was almost a rapid-fire-like thing. You did your job very well. Please stay back for the question-answer session. So, friends, those who are interested, those who already asked the questions, please wait. There was a question on leptospirosis regarding when can you diagnose leptospirosis by PCR. You can diagnose as early as possible, within hours of infection. Once the leptospiremia is there in the bloodstream, PCR can pick it up. So PCR will be positive within hours of fever. So even after the leptospiremia disappears in the bloodstream, PCR will be positive because the fragments will be there positive. So PCR is a good test that it's a rapid test, but only thing is cost is a prohibitive factor. You can do it. Some of the centers like ours, we do multiplex. That is, we do for dengue, scrub typhus, malaria, and leptospira together, so that we know when you have a doubt, you can, by PCR, we can find out, particularly in patients, pediatric children who are very sick in the ICU, we want to know the exact diagnosis. We do PCR multiplex. So there are some other questions to Dr. Raghunandan sir regarding dengue. You can answer. Regarding
Yes, sir.
scrub typhus, there are questions Dr. Suresh can answer. In the chat box, please look at the chat box.
Yes, sir. Actually, they are asking about pulse pressure, why there is fall of BP like that. That's what, because of volume loss, because of fluid loss, or because of blood loss, there will be fall in the systolic blood pressure. At the same time, because of the shock, there can be a peripheral vasoconstriction. So the systolic BP starts falling and diastolic pressure start rising. So that can narrow the pulse pressure. So that is where the early complications of narrowing of the pulse pressure from the previous value is very, very significant to assess the progression of the clinical picture. So that is where this thing. And what were the other questions? Sir, can you just take up the question here in the chat box as far as?
Sandil, can you open the chat box and see questions to Dr.
What are the precautions to be taken? Reinfection. That's what secondary dengue. I think they're talking about this thing. That's what, as I said, the complications of like going for a severe thrombocytopenia or a GA bleed or hemophagocytic syndromes, or it is immune enhanced antibody response. That is the reason for why secondary dengue is sometimes can be dangerous compared to the primary dengue. So that is where, if you want to know whether this patient is having primary or dengue, primary or secondary, you do both IgM and IgG maybe after 50 days. If both are positive, then you know it is a secondary dengue. So these patients need much more close monitoring. But at the same time, let us not forget that does not mean primary dengue cannot produce problems. It can also, but comparatively dengue, secondary dengue, we have to be more careful. And as far as anemic patients, some of the question, that's what I said, the initial hematocrit will give you the baseline value. As is sometimes the patient, the normal hemoglobin will be maybe 9 grams. So its hematocrit may be around 28 only. So that's what the guideline says, more than 20% from the baseline itself is also taken as a warning sign of hemoconcentration.
Regarding the scrub typhus, some questions I saw, people want to differentiate how to differentiate enteric fever and scrub typhus with more than 5 days of fever. Usually the basic history, any fever lasting more than 5 days, the chances of viral fever less likely. It's most likely between typhoid, scrub typhus, or leptospirosis. All the three is possible when a patient has got more than 5 days. So the history is, I have shown one of the slides, but because of time, I rushed through the slides. So it showed that the patient has got young people, particularly the typhoid is more likely in young people because people are eating outside most of the time compared to the elder people. And second thing, elderly people might have some typhoid previously, pre-existing immunity is also protecting. People are eating outside food. The chances are particularly weekly twice or weekly thrice are eating. Presence of fever, diarrhea, constipation, some amount of GI disturbances will be there. Not necessarily diarrhea, constipations or halted bowel habits. Along with fever, you think about a person is young person, WBC count is normal. You need to think about the patient has got most likely typhoid. On the other hand, patient, there's no age specific. Usually scrub typhus and leptospirosis, there is no age limit. Any person walking through the rainwater, wading through the rainwater, doing agricultural job, going to the bushy areas, fever lasting and more of headache. Here the patient has got classic symptoms, more of fever, headache will be there compared to dengue. Dengue has got more of back pain along with headache also. Here fever, headache, along with you're able to get some lymph node. If you examine the patient's HCAR is there, your job is over. Otherwise, conjunctival congestion for leptospirosis is going to help out. So young people eating outside, I think typhoid. People are doing agricultural job or suburban exposures or rural exposures, fever, headache. If HCAR is there, that's fine. If HCAR is not there, think about these things for making a diagnosis. But WBC is going to give you a clue. WBC normal, usually think of typhoid. WBC elevated, lepto and scrub. And similarly, LFT, more of hepatocellular pattern typhoid, more of cholestatic pattern or mixed pattern, think of leptospirosis and scrub typhus.
So there was one question on how to manage pleural effusion in dengue. I saw one question as actually, as far as plasma leak in dengue is mostly it is self-limiting. So we have to just monitor the thing and make sure that hydration and other, if there's any bleed like that, it's being taken care of. Very rarely, we had 2 or 3 cases in our ICU where when the progressive effusion was so much that it was causing physical distress to the patient. So we have tapped once or twice to take the pleural fluid out just for mechanical reasons. Maybe I request Dr. Suresh Kumar, has he got any experience of managing massive effusion in dengue by any other means?
Right now, we have seen a patient like a typhoid plus or minus dengue because the patient has got classic typhoid, blood culture proven, but the patient has got pleural effusions, ascites. So the dengue was thought, but dengue serology was negative. So HLH, hemophagocytic lymphohistiocytosis is also possible. Dengue we have seen, sir, but not massive effusions. Mild to moderate effusions we have seen. Once we start giving the proper fluid and proper management of the fluids, taken care by the pleural effusion is taken care of. The massive effusions we have not seen. The mild to moderate is usually seen.
So we can say it is self-limiting.
Correct, sir. Pediatric setting, we have seen massive effusions.
In pediatrics, we do see lots of children with the compartment syndrome, sir. Particularly when they come to the third stage, recovery stage, if IV fluids are continued beyond the second stage during the recovery stage, the fluid starts accumulating in the lung, particularly in the third spaces, and it will go in for compartment syndrome. You have lots of fluid. So the idea when the child is in recovery phase, that when the urine output is more than 2 ml per kg weight, and the hematocrit is stabilizing. But if the fluids are continued, the first thing you need to do is stop the fluids. First thing. And the second thing is, if the child is still in second stage, child is in critical stage, if the child is going for hemophagocytic syndrome, or the child is going for cytokine storm, sometimes the leak may be very severe, so that they will have a tense ascites and a massive pleural effusion. In pediatrics, it is advised not to tap the fluid. So in these children, we have to be very, very careful because tapping the fluid may lead to complications. Those children, you have to treat it as per WHO protocol. Rarely, as per WHO protocol 2019 guidelines in pediatric, we do use a small amount of furosemide in such cases where the respiratory compromise is there. In those cases with severe tense ascites and entrapment syndrome of fluid still in second stage, we use furosemide at the dose of 0.05 milligram per kg per hour as an infusion given over 24 hours. You have to be very, very careful. These children, you need to monitor urine output, you need to monitor the pulse pressure, you need to monitor the hematocrit, you need to monitor the vitals carefully and then give this, because furosemide should not be misused. It has been used only in very, very selective indications that is recommended by the WHO.
Sir, actually, you rightly said that inappropriate or over fluid parenteral fluid administration can trigger these effusions to aggravate. So I think that is also we have to keep in mind. Unnecessary transfusion, I mean, parenteral fluids can also worsen the plasma leak.
One question regarding the brucellosis. Again, brucellosis is also proper history. Usually, people contact with animals, particularly not only the goat, cow, even common goat. We need to think about the camels also. That particularly it is more common in what do you call the Far East people. So particularly the Middle East people is more common. So we need to think about the history of handling the animals. It's more important. And fever like a typhoid, it behaves like a typhoid. The fever lasts for more than 10 to 14 days. Usually the WBC count will be normal or below normal, splenomegaly. But a test like brucellosis, the brucella serology, a lot of false positive can happen. Cultures can give a clue, but again, cultures, the positivity rate is not great. But usually we can go with the history, fever lasting more than 15 days, contact with animal or unboiled milk consumption or cheese consumptions, unboiled things or raw cheese people consider. These are all the clue for brucellosis to me there. Instead of going for the test, brucella IgM. Brucella IgM has got again a lot of false positivity can happen.
Regarding CBC, I request all those learners who are in this CME, you can just make a reasonable guess what is the organism that is causing a fever beyond 50th day by looking at the CBC, as rightly pointed out by Dr. Raghunandan sir and Dr. Suresh Kumar. When you look at the CBC, look at WBC. If there is a leukopenia, think of dengue. If there is a leukocytosis, think of leptospirosis and scrub typhus. If there is a hemoglobin that is dropped, think of malaria. If there is a hematocrit that is rise, think of dengue and leptospirosis. If there is a eosinopenia, think of typhoid and typhus. If there is a eosinophilia, think of malaria. These four components just keep in the back of the mind. Whenever you see a CBC, interpret wisely. Just by interpreting CBC, you can make a reasonable guess what is the organism causing this monsoon illness. That's very CBC is a very important tool.
There is one question regarding the use of papaya leaf extract. I think it has entered the market and there are many people are using, but I don't think there's a strong evidence to use papaya extract in the management of dengue, to best of my knowledge.
The important message is, please remember, dengue is not a platelet disease. You can have a normal patient with thrombocytopenia. You can have a very sick patient with a we can have a normal patient with a thrombocytopenia. At the same time, you can have a very sick patient with a normal platelet count. So basically, remember, dengue is not a platelet disease. So there is no point in giving drugs to increase the platelet count. You have to treat the patient, not the platelet. Very important message. Do not refer the patient just because patient has got thrombocytopenia. But at the same time, you have to look at the patient's general condition. Is danger signs. If there are danger signs, you need to refer them as early as possible, even with a normal platelet count. So do not give drugs to treat the platelet thrombocytopenia. Dengue is not a platelet disease. That's an important message. From today, focus on patient. Do not focus on platelets.
Actually, sir, if platelet is not improving even after 4 or 5 days of settling of dengue, please think of any other because in our lot of other platelet deficiency disorders like ITP, like that. So if platelet is not improving, say even after 10 days, something like that, please check for other reasons and rule out other possibilities, because they may be having some other disease. The dengue has brought them to the hospital. So that also you should keep it in mind.
That's a very valid point. Basically, dengue is a 11-day illness. The fever is beyond 11 days. There is hepatosplenomegaly or there is a bicytopenia, or in these conditions, the persistent thrombocytopenia, in particularly in children with hepatosplenomegaly with the involvement of other cell lines, you have to think of HLH, hemophagocytic syndrome. In those children, please do peripheral smear study, do a serum ferritin, do triglyceride level, and make sure that the child does not have HLH. It is better to refer the patient to a center where they got pediatric ID specialists, so that they can do further workup regarding HLH and they can be managed with IVIG. These children, recently we had one child referred from a village near Udmalpet. The child came on 13th day of fever with dengue. The child had a severe HLH and that child recovered very well with IVIG. We made a diagnosis of HLH. We had hemophagocytic cell in the bone marrow and the child did extremely well. Today the child came for review and the parents are really happy. So in such cases, you please refer. The thrombocytopenia persists continuously. You have to think of other conditions other than a simple dengue.
Similarly, during the recovery of phase, we talk about febrile, critical and recovery phase. Just for the primary care doctors, just we have to keep these things. During the recovery phase, we have observed 3 things. One is rash. During recovery also, we have seen some rashes. One. Number 2, they may have a relative bradycardia. So don't get panic. As long as the hemodynamic is stable, no symptoms, they are having a heart rate of say around 50, 60 like thing, which takes some time for them to recover. That is number 2. Again, in pediatrics, I think sir will agree regarding itching. They may have some kind of itching during the recovery phase. That also we have observed. Similarly, they say even the discharge criteria for dengue, they are telling about the increasing trend of platelets. So on that, the worst platelets say around 20,000, but platelets start improving 40, 60, 70. Don't worry, if it's increasing trend, we can wait. Maybe even up to 1 month, we can wait. And if it as long as no other problem as such. So that also we have to keep it. You do not worry too much on these some common things which we observe during the recovery phase.
One question regarding
another important clue that doctors can do is, if you have a thrombocytopenia, look at the mean platelet volume. If it is good, probably child is recovering. Another important thing, what we see in particularly in 5-part cell counter, is that we see immature platelet fraction. So IPF. That is a good indicator for a sign of recovery. You need not worry. You need not give platelet transfusion. That's a very important thing. And once again, there are many secrets in infectious disease. Once again, those participants who are here, if you want to join this infectious disease certificate course, please contact me in the above number 984221179. Still, the registration is open. You can join.
Regarding one question regarding the clinical malaria and peripheral smear is negative. Usually the peripheral smear depends upon your technicians. If a technician is a senior, he can spend some time and rely on peripheral smear. Otherwise, you got access to the QBC, the method is better. But of late, we are seeing less number of cases of malaria. Last 10 malaria cases for me, all are imported malaria. That means Indian going to the Africa or African countries coming back with malaria. For me, all are not Chennai. So these are all the cases I'm seeing. So malaria is no more number one. Dengue is number one right now. Previously COVID, now dengue is taken over for the last couple of months. So think about dengue or other viruses. If malarial smear is negative, if couple of times is negative, don't give empirical chloroquine. Now the government of India has removed previously presumptive treatment of chloroquine for any fever patients after taking smear was there. But now the presumptive treatment government of India has removed from 2010. Two, WHO removed the entity called clinical malaria. So don't write in here discharge summary clinical malaria. People can go and tell there is no malaria, writing clinical malaria. So don't consume. If you do not have the access, the patient is really sick in ICU, that point of time, couple of doses of empirical antimalarial avoided can be allowed. Otherwise, for a walking, talking patients in the ward patients, you need to demonstrate the malarial smear either by means of rapid card or by means of smear or by means of QBC, but don't go by clinical malaria for a ward patients, for OP patients. Sick ICU patients, where turnaround time is longer or other things are negative, malaria cannot be excluded 1 or 2 doses before you think other diagnosis. That's what we need to do. I think a lot of questions keep coming up there. Since I got an emergency, emergency when patient come there, I might leave, but I given my number. So anybody want to contact me there, please feel free. So I'm answering my leisure time there, no issues there. You can message me, they can do it.
Sir, there was a question about antibiotics in dengue. Dr. Raghunandan sir, Dr. Suresh, you can answer about antibiotics in dengue.
People want to use doxycycline as an anti-inflammatory agent. There are a lot of anti-inflammatory agents, so do not use doxycycline. There is no role. There is no role for doxycycline or no role for any antibiotics. Even for COVID, people are not using azithro and doxy. So don't use any antibiotics. That's definitely not needed. People are asking about this papaya leaf there. Again, there is no RCT. There is no randomized control trial. On day 5 to day 6, they did the trial with the company-sponsored trial that showed day 5, day 6 ablated. That's automatic recovery, but the company claimed it and people start using that medicines for everything. So need to remember hospital code. Patient need to recover from 2 things. 1, from the disease, what he suffer. 2, what the medications you start. So always think the medications always has got side effects. Don't think this is a harmless one. This is not going to cost anything there. So always think in mind, essential, start. If it is not essential, not life-saving, if there is an RCT evidence-based thing, you can start. If there is no evidence, do not start. Because companies can market like anything, they market it like anything. People are using all dengue patients I'm seeing there. In fact, we are doing an audit there. We have seen almost 80% to 90% of clinicians audit showing that the papaya leaf extract preparations is mentioned in the prescriptions. So please do not use it without evidence. Eosinopenia, people are talking about it. Eosinopenia is a marker of typhoid most of the time. Usually any systemic infection, say that eosinopenia, maybe in brucella or maybe in the typhoid is a marker, but along with WBC count should be, there are 4 parameters. WBC count should be normal, neutrophil count should be normal, eosinophil should be absent. Then third thing is ESR should be normal. All the parameters, but only selected lab it is positive, not in all other labs. So very few labs only is doing it, so we can able to do it. Durations of antibiotic in enteric fever. Durations of antibiotic is little longer because this is an intracellular organisms. We need to treat minimum 7 days, ideally 10 to 14 days. Depends upon the agent. Do not use fluoroquinolone. Either you can use azithromycin, 7 days is fine. If you are using 3rd generation cephalosporins, 10 to 14 days is needed there. And what else are the questions? I'll shoot it up there before I leave.
There was a question about dengue in pregnancy, sir. Dr. Raghunandan, sir, you can talk.
Yeah. Actually, as I already said, any fever in pregnancy is a high risk, so they have to be admitted and watched. Again, as far as management is concerned, it is nothing special for pregnancy. Only thing is they need much more close observation and monitoring. and again, it can cause high morbidity or mortality in a case. Something like, in fact, they say, as far as malaria is concerned, they say even the mortality can be up to 50%. Again, special things about dengue in pregnancy, they have to be admitted and watched. That's all.
Is there any, if Dr. Raghunandan sir, you can give some
Actually,
carry-home messages.
Before we conclude, so the general, I mean, carry-home message, what I could tell our colleagues is, any acute febrile illness, especially if it's going to be a viral illness, it's a self-limiting infections. Even bacterial infections can be managed, but some of them can land up in complications. So in our busy practice, whatever the diagnosis, for example, sir was mentioning about scrub. The most important complication that we see in scrub is ARDS, which is a very good recovery. Almost with IV doxy or IV azithro, they do very well. But it should be administered very early so that patient comes out of ARDS quickly. Similarly, as far as Weil's disease is concerned, we see, of course, GI bleeds. We have seen those days. They can go for acute kidney injury. All these complications can be prevented by early diagnosis and appropriate antibiotics for lepto or for scrub. But as far as dengue is concerned, again, I agree strongly with Dr. Suresh sir that there's no role for doxy as such for dengue. But in a busy practice, if you are suspecting lepto or scrub, if you are suspecting lepto or scrub with or without further confirmation, I know the limitation of confirmation not available in every case. You can start doxy, but only thing is doxy cannot be started for a pregnant woman, for children less than 7 years of age. So for them, maybe you can try azithromycin if your clinical suspicion is strong, or if you're able to prove the diagnosis of scrub or leptospirosis. Similarly, the value of eschar. Thing is, eschar may not be there in every case. I think if I'm right, the literature says 30 to 40% only may have eschar. So just absence of eschar clinically again does not rule out, as Sarah has nicely mentioned, about presence of lymphadenopathy. It's a very, very important. In fact, scrub is a disease of 3 weeks. The first week they come with fever, lymphadenopathy, jaundice, something like that. Second week is of complication. Especially they can go for acute deafness, I believe. They can go for a deafness like that. Again, it can cause multi-organ myocarditis. Again, the most characteristic is ARDS-like picture. So sometimes the early diagnosis in appropriate doxy or azithro can revert the disease completely. So in our practice, find out again, spend time with the history and good clinical examination. Number 2 is follow-up. Follow-up is very, very important, and appropriate referral early if need arise. So that's what I want to tell you.
Thank you, sir, for giving your valuable inputs, particularly carry-home messages. Suresh, you can please give your carry-home message.
So tropical fever is most difficult thing to deal with it, but with a proper history taking and examinations, listen to the patients, examine the patients from head to toe, you can make a diagnosis. What are all the history? Travel history is more important. What he eats, what he does, that's most important. So remember, and similarly do the basic examinations from head to toe. Look for eschar, look for spleen, look for rash. These things is very important. And if you are not able to do a basic decent lab test for CBC, LFT, most of the problems you can solve. For day 5 to day 7, if you are not able to get the answer, we can give a trial of azithromycin that will cover common stuffs what is surrounding, and even with 2 to 3 days of response is not there, specialists are available. Please use the specialist cell for at least we can get a consult over the phone. It's not like a chargeable there. We can get a consultations. We can guide you what to do, what not to do. It's not they're going to charge you for everything there. So you just give a consultations for you there. Just discuss with your colleagues. They can give a good answer for you people. So please feel free to contact us and learn. This IMA CGP course is very wonderful course. Just similarly learn more ID. This is not for practical. People are asking whether it's a TNMSC registered credit or not. TNMSC can give credits. It can't recognize these things there. So usually if you want to learn, deal better, learn these things or attend. Similarly, IMA CGP, some people wanted to suggest every month also. We are happy to provide a lot of courses. If IMA CGP can provide a platform like this one, we can definitely share the knowledge what we are having it. So please feel free to contact. We can help you at any point of time. Thanks for the wonderful opportunity.
Thank you, Dr. Suresh, once again for giving valuable inputs regarding monsoon illnesses. Friends, once again, I request all of you to join this infectious disease certificate course. Additionally, along with the certificate, you will also be getting 10 credit hours from Tamil Nadu Medical Council. Please remember, this certificate course is not a medical council recognized certificate course. That's a very, very important point that you must know. This is a certificate that is given by IMA, Tamil Nadu State Chapter, ICGP Wing. And I request all of you to join this course to make your practice more useful and more scientific and rational. I like to thank my speakers, Dr. Raghunandan sir and Dr. Suresh Kumar, for your excellent, valid inputs and very, very scientific and rationalize our practice. Really, thank you very much for sparing time, nearly 3 hours with us. And I like to thank Dr. Sengutuvan, Dr. Sendil, Dr. Rajkumar, the IMA CGP chairman, secretary, and the representative for giving us this opportunity. On my personal behalf, I would like to thank all the 1,000 delegates who joined this interactive session. Please remember 3 important things. A child with dengue, please remember, dengue is not a platelet disease. From today, please focus on the patient, not focus on the platelets. That's a very, very important message. Number 2, if the child has got a fever of beyond 5 days, child has got a conjunctival suffusion, please make an empirical diagnosis. There is a bifrontal headache and child has got chills with rigor. Please keep leptospirosis in the back of the mind. If there is there is a splenomegaly, there is a eosinopenia with a fever that is persisting with polymorphonuclear leukocytosis. Please keep typhus in the back of the mind. These 3 are very, very important. If you are unsure about your diagnosis, the child is really sick, it's worth giving a trial of doxycycline in children above 8 years and worth giving a trial of azithromycin in children less than 8 years. Usually, the response is dramatic in leptospirosis and scrub typhus. You can see the child recover within 3 doses. Within 48 hours, child sit up and start playing. The fever that is there for 7 days will dramatically improve with 3 doses of doxy or azithro. That's a very, very important thing. So you can give what the therapeutic trial of doxy and azithro is indicated empirically in a setting where there is a history, there is a clinical examination points towards lepto and scrub. And antibiotics, steroids, IM injections, BD IV fluids have no role in dengue. Please remember, when the patient has got danger signs, you need to admit them, give IV fluids 24 hours. Do not treat the patient as outpatient, giving BD IV fluids. And do not give steroids, do not give IM injections, do not give antibiotics, do not give drugs to improve the platelet count. These are all not indicated. They are not recommendations by WHO. With that, once again, I thank you all for this joining this course. Thank you for joining us. And let's all make our state monsoon illness mortality-free state. Thank you all. Thank you.
Thank you, sir. I'm Dr. Segutuan. I really congratulate all the 3 speakers who are eminent, experienced, and widened the knowledge. And you explained everything in detail. And what is more important to be considered, it will also explain to the participants. So I request all the participants to join the certificate course run by the IMA CGP. So to increase the widened knowledge and experience your practice as a family physician. Thank you one and all for the opportunity given to them. Thank you, sir. Thank you.
At the outset, I really thank all our speakers, participants, and delegates, registered participants for the conference all along 3 days. And this conference actually is a part of our academic activity. We have 2 types of academic activities. One is CGP monthly CMEs. The other one is CGP certificate courses. The certificate courses are structured one. In the sense, the entire syllabus is fixed. All the faculties have formed the syllabus meticulously, and there will be a periodical reviews, question and answers and all the exams, everything. So I request all of the members to join the certificate courses and get benefited. And the same thing will be done in an extraordinary way and in a much refined way. And the other thing is now regarding this conference, there are almost 2,000 plus delegates, and we are just checking all the Google Forms and making it ready for the TNMC creditors processing. So I request everyone to clear and fill the Google Forms if not filled already. Those who have sent the payment screenshots in the Google, in the WhatsApp groups, kindly fill the form and close it up. And I thank you again for joining the session, and we will do it next time in a much better manner and with all facilities and easy and hassle-free ways. And I thank all our CGP office bearers, our president, secretary, and our chairman, Dr. Sengutuvan sir, and all our joint secretaries, Rajkumar sir, governing council member, alternate members, and everyone. So this is a note of thanks, and I hand over to Dr. Sengutuvan sir. Thank you, sir.
So once again, I thank all the speakers for their eminent expert knowledge given to the participants. I thank Dr. Naimnathan. I thank Dr. Raghunandan. I thank Dr. Suresh Kumar. I also thank all the participants who have participated in the CME program and the conferences. If anybody attended all the 5 days, please, if you have not paid the registration fees, please pay the registration fees after filling the recruitment forms. Thank you. Thank you all. Thank you, my dear Sendil, for the nice
and thank all our
everything. Also thank all my official CGP partners, Rabindranath, Dr. Chinnadhara Abdullah, Dr. Rajkumar, Dr. S. Veerapandian, and Dr. Jayakumar. I also thank our state president, state secretary, and other office bearers. Thank you, one and all.
Thank you, sir. Thank you.
Thank you, Sendil.